Mumbai for Electrophysiology conference. It's an honor to stand before you today as we gather for the conference. We come together not only as healthcare professionals, but as a community dedicated to promoting health, compassion, and excellence in patient care. I would like to invite Dr. Sanjay Kumar Talkekar to come on stage and start with the introduction.
Can you start this? Happy and healthy good morning to all my dear friends. This problem is with all the interventional cardiologists. A warm welcome to all of you, and first of all, thank you for sharing your valuable time. We know it is a Sunday morning, it's difficult to stay away from the family, but thank you for all of coming for this thing. Medical sciences is growing exponentially, and it's our duty to be part of it. At least we should know the things. At the same time, we should not miss the clinical skill also. So this conference is aiming to revise improve our clinical skill, as well as we'll also have to evidence the latest development in the field of electrophysiology and spacing. So each and every topic is handpicked, especially with the Dr. Saurav Deshpande, who is electrophysiologist with us. We discuss a lot and we pick these topics. So trust me that we will enjoy this way of learning greater way. So first of all, I will hand over my mic and we'll start the proceeding with the conference.
Thank you, sir. Lighting the lamp of knowledge and wisdom. This is a symbolic movement that signifies the dispelling of darkness and igniting of enlightenment. It's an honor to invite Dr. S.V. Kulkarni and Dr. Vinay Shriram, Chairman and Secretary of API-NM, on stage to do the honors. I would like to invite Dr. Sanjay Kumar Talkekar, Dr. Mahesh Bhogre, Dr. M.V. Reddy, Dr. Rajesh Kumar Tolwar, Dr. Saurav Deshpande, Dr. Hemant Kokane, and Dr. Matwadi to light the lamp. Thank you, everyone. The lamp has been lit. I would now invite Dr. Mahesh Bhogre to start. Chairperson Dr. Ninad Audrey, Dr. Keshav Kare, Dr. S.V. Kulkarni, please come on the stage. Panelists Dr. Bharat Agarwal, Dr. Babita, Dr. Varun Shetty.
Good morning, everyone. So today we will start with ECG in the diagnosis of acute chest pain in emergency. Lights off. So though majority of the patients, those visit to the ER with chest discomfort have non-cardiac causes, almost 1/3 of the patients do have cardiac issues. So it is always important to get ECG, but whenever we get ECG, the first and foremost thing we should do is we should confirm the standardization whether this ECG meets normal standardization or not. And so ECG paper rate should be at the rate of 25 mm per second, and this standardization should be 10 mm. So low and high amplitudes, half and double standardization can make us wrong ECG's interpretation in the form of chamber hypertrophy or loss of QVS or unnecessary QVS. So there should not be over dampening, overshooting or under dampening. So that again gives rise to confusion in the interpretation of the ECG. So first thing we should do is to localize the territory which part of the heart is involved. So V1 to V4 leads generally represents anteroseptal. 1 AVL, V5, V6 indicates lateral wall of the heart. 2, 3 AF is inferior, and AVR indicates left main. So coming to the first ECG, 54-year male with typical angina of 2 hours duration. This was the ECG taken when he came. So we can't see ST elevation in this ECG. There is clear-cut ST depression in inferior leads 2, 3 and AVF, but as such there is no ST elevation. But this is second ECG taken 10 minutes later. So it is showing clear-cut anterior wall myocardial infarction. So whenever we get patients with chest discomfort, it is common customary that we should repeat the ECG so that we should not miss the findings. So serial ECGs along with clinical judgment coupled with imaging, that is 2D echo. If these patients come, first and foremost thing we should do after ECGs, we have to see the 2D echo. We got one patient recently, ECG was showing some minor STT depressions, and we have done the echo. There was dissection of the aorta. In such cases, imaging is totally different. We should not rush these patients to the cath lab. So these patients should go to the CT for CT aortogram to see the extent of dissection. So not all STT changes we should rush these patients to the lab. So second ECG, this patient had looks like a right bundle branch block in V1, V2, V3. There is no clear-cut ST elevation, but when we look carefully in lateral leads, that is V4, V5, V6, 1 AVL, there is some ST elevation. So this is Q with right bundle branch block. So we call it as QRBB. This is synonymous with anterior wall myocardial infarction, and this indicates LAD block proximal to the first septal origin. So this is omnious indicator of ST elevation. So in STEMI anterior wall MI, we could get either QRBB or typical STEMI anterior wall MI. So coming to the next ECG, so we have got global STT depression in all leads except V1 and V2. The most important finding here is ST elevation in AVR lead. So whenever we get ST elevation in AVR along with chest pain and some ECG changes, we should always think of either a critical triple vessel disease or left main disease. So again, this is very important. So next is 56-year diabetic female with chest pain, and this is the ECG. There is no ST elevation or ST depression, but what we can see is all anterior leads are showing biphasic T waves. So this is omnious indicator of proximal LAD occlusion. We call it as Wellens syndrome. So Wellens syndrome has got two presentations. Either this could be biphasic T waves in all leads, or there could be symmetrical deep T inversion in all anterior leads. Coming to the next case, 37-year-old male. He gives history of chest pain radiating to the left shoulder. He gives history of fever since last 3 days. So what we can see here is ST elevation in 1 AVL, V5, V6 side as well as lead 2. So there is no typical localization of the territory, whether it is left anterior descending or right coronary artery. So if we look carefully, there is ST elevation with concavity upwards. There is ST depression in AVR as compared to previous ECG. Whenever there is ST elevation in AVR, that indicates left main or triple vessel disease. But when there is ST depression in AVR, this is more likely of pericarditis. So this is pericarditis. Again, there is PR segment depression, which is not seen in ischemic heart disease. So how to differentiate between pericarditis and STEMI? So in pericarditis, generally we don't get Q waves, we don't get reciprocal STT depression, and pattern of evolution of pericarditis and STEMI are totally different. So in pericarditis, first there is ST elevation, then ST segment comes down, that is J point comes to the normal, and after that T gets inverted. While in case of STEMI, we get Q waves, ST elevation, we can get T inversion along with ST segment. This never happens with pericarditis. And once there is resolution of STEMI, so we will get residual disease in the form of Q waves, which is not seen in pericarditis. Next is 60-year male diabetic with typical angina. This is the ECG. So this ECG is not pathognomic of any territorial heart disease, means sub RCA, LAD or circ disease. If we look carefully, there is a slight ST depression in lead V2, V3 and V4. So basically there is R wave in lead V2, V3 and some ST depression, but there are no reciprocal changes. But this patient had typical angina. So this indicates true posterior wall MI, and this should be treated like a STEMI. This is commonly missed electrocardiogram routinely. And often this inferior posterior wall MI is associated with lateral wall myocardial infarction. We should get lateral leads in such cases to see whether this is true posterior wall MI or not. So what we have to do whenever we get ST depression in V2, V3, V4, so we have to tilt the ECG upright, and we will see in that case this positive R wave becomes Q wave, ST depression becomes ST elevation, and this upright T wave becomes a T inversion. So this is typical anterior myocardial infarction. So this patient, these are lateral leads V7, V8, V9 showing ST elevation. Next is young male with shortness of breath and chest heaviness. He gives history of prolonged road travel. There is some ST elevation in V1, V2, V3. At the same time, if we see, there is lead S in lead 1, Q and T inversion lead 3, that is S1, Q3, T3 pattern, that is diagnostic of acute pulmonary embolism. So acute PT can present with any sort of ECG. The most common presentation is sinus tachycardia. It can present with right bundle branch block, T inversion in anterior leads, T inversion in inferior leads, right axis deviation, or S up to V6, which shows right ventricular hypertrophy, or report it can present with only sinus tachycardia also. Next is 40-year male, known case of rheumatic heart disease. 40-year female, known case of rheumatic heart disease, presented with chest discomfort and breathlessness. This was the ECG. There are no POs in this ECG. This indicates this is atrial fibrillation, and this patient was on digoxin. With time, the use of digoxin is going down. The only indication as of now to use digoxin is those patients who got LV dysfunction with uncontrolled heart rate, that to atrial fibrillation. So less commonly we see these patients nowadays. This is typical reverse check or reverse tick sign, indicates digoxin effect, not digoxin toxicity. And digitalis per se can give rise to any sort of arrhythmias except atrial fibrillation and atrial flutter. Next is 46-year male, hypertensive, with chest discomfort and left arm heaviness since last 1 week. This is the ECG. There is ST depression in 1 AVL, V5, V6. So whether it is ischemic or non-ischemic, as per protocol, we have to repeat the ECG, we have to get the cardiac enzymes. BP was 200/100, cardiac enzymes were negative, repeat ECGs were same. So this is hypertension with left ventricular hypertrophy with stent pattern. So it can occur in any sort of LV outflow obstruction like aortic stenosis, coarctation of aorta, or hypertrophic cardiomyopathy. So how to differentiate whether it is LVH with stent pattern or ischemia? So generally in LVH, the first sign of LVH on ECG is loss of normal Q waves in lateral leads. That is 1 AVL, V5, V6. These leads show small Q waves normally. So loss of normal Q waves is first sign of left ventricular hypertrophy. Then the pattern of ST depression and T inversion also indicates left ventricular hypertrophy. In patients with LVH, these T's are asymmetrical. The upstroke of T wave is generally steep and it tends to overshoot the baseline. And depth of this T wave is generally more than 3 mm. This is very important. And if there is T inversion lead V3 also, so T inversion in V6 is more than lead V3 when there is left ventricular hypertrophy, and this is not the case in ischemic cases. These are extreme forms of left ventricular hypertrophy showing Q waves and deep T inversions typical of hypertrophic cardiomyopathy. Whether it is obstructive or non-obstructive, we get these ECG changes. Next case is young male with some funny sensation in chest followed by syncope. He had loss of consciousness. He gives history of sudden cardiac death in his brother, and this was the ECG. If we see there is some ST elevation with coving in V1 to V3. So this is typical of Brugada. It is very important to identify this Brugada pattern. There are 3 patterns. Only one type 1 pattern is diagnostic. These ECG changes are generally precipitated by some sort of infection, fever, or some sort of medications. It is why it is important to recognize this entity. That is, these patients are very prone for ventricular tachycardia or ventricular fibrillation and sudden cardiac death. This is next case, 55-year male with chest pain, and this is the ECG. This is common scenario, and this is highly confusing. Left bundle branch block pattern. So majority of the patients presenting to the ER with LBBB have normal coronaries, but if it is new onset LBBB, this indicates myocardial infarction, and this warrants emergency PCI. So how to differentiate between normal left bundle branch block and abnormal LBBB, that is ischemic LBBB. So normally there is rule of appropriate discordance, means whenever there is normal LBBB, the QRS is upright and ST and T are down. The same is when QRS is down, the ST and T are upright. So this is normal appropriate discordance with normal LBBB. But when there is concordance, that is QRS, ST and T are upright, or QRS and T are down. So when there is concordance and 1 mm ST elevation or 1 mm ST depression, then this is probably related to myocardial infarction. And when there is discordance but ST elevation is more than 5 mm, this indicates myocardial infarction. This is very common scenario. Young patient generally present with global STT elevation. This patient has ST elevation V2 to V6 and inferior leads. This is early repolarization syndrome. So what indicates ERPS is concavity upwards in all SC segments. There is J point notching and prominent and slightly asymmetrical T waves. So previously it was thought that all ERPS patients are benign, all ERPS are benign, but this is not the case. There are some malignant forms of ERPS as well. ERPS also is prone to ventricular arrhythmias like ventricular tachycardia and fibrillation, especially when there is horizontal or downsloping ST segment. Coming to the last ECG, 60-year female, recent loss of close relative, it's with severe chest pain. This is the ECG. This is typical of acute myocardial infarction. This patient was rushed to the lab after 2D echo. 2D echo was showing anterior wall hypokinesia. but surprisingly angiography was normal. So this is thus echo will help us to come to the diagnosis in this case. This was the echo, typical apical ballooning of the left ventricular LV apex. So this is Takotsubo cardiomyopathy. Takotsubo is Japanese name for octopus track. Why it is important to recognize this entity? Because management only supportive, and we have to avoid catecholamines. That is all inotropics we are supposed to avoid whenever we detect Takotsubo cardiomyopathy. That can be disastrous. So to recognize this entity is very important. It can give us to any sort of ECG changes like ST elevation, T inversion, prolonged QT or prolonged PR segment. So coming to the end, ECG in the chest pain, this is probably the single most important investigation, which is easy, quick and cheap. To interpret ECG is the art and science. Always consider history and clinical examination. And not all STT changes are coronary, or not all coronary syndromes are present with classical STT changes. Thank you.
Thank you, ma'am. You have covered the subject really very nicely. And we must thank one person, William Binborn, who might have sat in a room of this size hundreds years back and thought of recording the electrical activity. Can you throw some more light on how to diagnose Brugada? Because this is one of the very common presentation when we go for routine medical checkups or even the pre-operative medical checkups.
Sir, Brugada basically there is ST segment elevation in V1 to V3. Generally it is saddleback. So EP study, EP guys will throw more light. Dr. Vivek Kokne Hemant.
Can I get mic? Because you said that the changes are dynamic.
Yeah.
And can they be provoked or can they be minimized by some manuals or some drugs?
Yeah.
There are certain tests, as you mentioned, there are certain provocative tests. Earlier it was Ajmalin was advised, but Ajmalin is not available anywhere. So a substitute here is flecainide, which can be given orally, and then we can monitor the ST-CoV, whether it is increasing or decreasing. So that is one thing which can be done. Apart from that, genetic testing is important. Few centers they have, and I think that.
Is it recommended to go for provocative test?
Not actually, unless there is a strong family history or the patient himself has a history of loss of consciousness or any syncopal episode, pre-syncopal episodes, then it is recommended to go ahead with genetic subjects. Absolutely asymptomatic, we can wait.
Say, like in this patient, he had a loss of brother with sudden cardiac death.
Yeah, then yes. It is relative first relative sudden cardiac death.
But provocative test itself can initiate ventricular fibrillation that can cause sudden cardiac death. Generally, it is not done also, sir. So this is a clinical diagnosis on the ECG.
Just one comment. So whenever you get a patient where it is suspected to have Brugada, always remember that Brugada syndrome has problem in the RVOT. The ECG leads which we keep at V1 and V2, that is the diagnostic leads for Brugada, that is kept at 4th intercostal space normally. That is the routine ECG thing. Whenever you are suspecting Brugada, V1 and V2 have to be kept at 2nd intercostal space to confirm whether the patient has Brugada. So what happens is when sir showed you 3 patterns, out of which sometimes you will see type 3 pattern, that is saddleback pattern, when your leads are V1 and V2 is in 4th intercostal space. Just put them in the 2nd intercostal space, you might get type 1. Why it is important is there is no significance of drug-induced Brugada. There is no treatment required. Even if you do a flecainide challenge test and patient becomes positive Brugada, there is no treatment required. But there is importance of spontaneous Brugada pattern. So whenever you have a spontaneous Brugada pattern, that is type 1 pattern, that will make you give medications, or as in this case, in the case of syncope, you have to put an IC. Specifically, then you have to find out which Holter and with the TMD that the patient is actually prone for these arrhythmias, and then go for further treatment.
Do you feel that you're routinely taking B3R and B4R in such situation with help?
No, sir. B3R, B4R will not help. So that is why I told you the problem is in right ventricular outflow tract. So those two leads have to be kept higher, not rightward. Problem is higher, not rightward.
Thank you.
Sir, thank you, sir, for a nice lecture. Sir showed two nice ECGs. One was balance and other was QRB anti-wall MI. Both we tend to see them in our routine practice, day-to-day practice. The only things are we should not miss those ECGs. Balance has a type A and type B pattern. Type A, where there is a biphasic T wave, as sir mentioned, which is seen in anterior leads, and type 2, there will be deep T wave inversion seen in anterior leads. The important thing is balance is patient may or may not present chest pain, and patient's troponins may or may not be raised. So you have to be careful. The patients are generally young patients, and when we do coronary angiogram, there will be a proximal LED lesion over there. And QRBB anterior wall MI, these patients tend to crash. They are very serious patients. They are generally ostial LED lesions in such patients. So you have to be very careful. You have to be very immediate acting in QRBB anterior wall MI patients. Thank you, sir.
Even recently we have got one patient with anti-wall MI who didn't have any ECG changes. That was seen pick only on 2D echo. LED was totally occluded. So ECG, we can miss the diagnosis. So clinical examination in 2D echo is more helpful along with the ECG. Thank you.
Thank you, sir. We would like Dr. Kalpekar to felicitate our speaker with the panelists. Thank you. Thank you, everyone. Thank you, sir. We would like to invite our next speaker, Dr. Brajesh Kumar Kurwal, with the chairperson, Dr. Tamiruddin, Dr. Rishikesh Thakur, panelists Dr. Pallavi, Dr. Savita, and Dr. Farah.
सर खोल दो ना ये फर्स्ट वाला ये पीवीसी में
So, good morning everyone. A very important topic. Now, why it is important is because almost all of us must have seen ECGs coming like this in our OPDs. Some people come with this ECG for fitness. I mean, I recently, yesterday, had two patients who got selected for Merchant Navy. Their ECG showed one VPCs. Now they were rejected. They said, go and meet cardiologist and come back. Now you tell me what to do. I mean, we should understand what is VPC. That VPCs can be very benign. Then can I as a cardiologist say, nahi, Baba, you are not fit for Merchant Navy job? So that concept need to be cleared among ourselves. Which VPC is an important one clinically? Which VPCs we should stop that patient that Baba घर पे रहो, treatment खाओ, Merchant Navy में जाने की जरूरत नहीं है. So these things are important when we talk about VPCs. So we all know what is VPCs. Probably it's an extra beat which arises distal to the AV node. And there was a time when people will hardly have an ECG in their whole life. But nowadays, you join any job, you join any office, the first thing will be health checkup. Because we are screening more, we are doing ECGs more, we have more gadgets. For example, our watches are having ECG recording. We frequently order Holters, which were not available a decade back. So that is why we are able to catch these VPCs very frequently. Now, once you catch these VPCs frequently, you will have a confusion now what to do with them. So that is the reason why these are some of the gadgets which we very frequently use nowadays to pick up these VPCs. Now, mechanism, I'm not going into details of that, but yes, there are 3 mechanisms by which you can have. One is the abnormal automaticity, re-entry, and triggered activity. I'm not going into that. But what is important is how to evaluate these patients. Now, you can have 2 types of presentation. One, the patient can come absolutely asymptomatic with you. Patient does not have any symptoms. You just see the ECG and say, "Arey, VPCs hai, nothing to be done," you go home. The second is the patients who come with symptoms. Now, these symptoms can be palpitations, can be pre-syncope, can be dyspnea, can be fatigue. Now, it all depends also on the number of VPCs they have, the frequency, how much the VPCs they have. Sometimes the patient don't come with the VPCs alone. They come because of the effect of those VPCs. Those VPCs effects can be heart failure, can be prolonged multiple episode of VPCs, somewhere mixed with VT, so patient can have syncope as well. So presentation can be totally asymptomatic. Patient VPCs were picked in health checkup, or sometimes the presentation can be because of sequelae to VPCs, which can be heart failure, which can be VT. Now, what is important is whenever you have a VPCs, please take a good history. There is a possibility that somebody can come out to be a Brugada syndrome, as rightly said in previous speaker. Somebody can have ARVDs with history of sudden cardiac death in family. So taking a proper history becomes very, very important. We call these histories are malignant histories. Now somebody comes to you, say, मेरा भाई 30 साल की उम्र में सडन डेथ में मर गया, मेरे घर में तो सब लोग 40 साल से पहले हार्ट अटैक डेथ सडन डेथ हो जाती है. Now that history is very significant when you are evaluating a VPCs. So if the patient has got suppose incidental VPCs, now you look for the most of the time, what has happened during COVID time, everyone had a pulse oximeter. So they connect the pulse oximeter and suddenly you see a pause, you see heart rate 40. That 40 heart rate is because of the compensatory pause. You have an VPC followed by a compensatory pause, so the patient will pick, "Arey doctor sahab, heart rate mera 40 ho jata hai." So that was one of the most commonest reasons why these patients used to come to us, because they will feel the heart rate is less. Actually the heart rate is less only because of a VPCs coming. So when you have that, look for observe the patient for these features like bradycardia, irregular heartbeat. Look for signs of heart failure. Look for restriction of activities. Some people restrict their activities because they think more activity they will do, they will have more VPCs. So then, if you have first of all, make sure whenever you have a patient with VPCs, take a full 12-lead ECG. You can order, Holters. You can order something like a 24-hour or 72 hours. By seeing an ECG, we get lot of information. For example, you can have For example, this is an ECG. Now this ECG comes to you. When you see this ECG, you find that there are multiple episodes of VPCs. Now, by seeing the morphology of these VPCs, you can find it out from where it is arising. Now, if you see V6, this is an RBBB. So RBBB means, RBBB morphology VPCs means V6 is an LBBB morphology. Once you have an LBBB morphology in the ECG, that means it is arising from right side, right ventricle. Now you see the axis. If you have an inferior axis, then this ECG, these VPCs are arising from RVOT. So this is how we make it. You see that lead 2, 3 AVF is positive. That means it is arising from the RVOT. This is how you can make it out whether this ECG is arising from which part of the heart. Now when we see as a cardiologist this ECG, we also look for other things. For example, how broad did the VPCs, what is the coupling interval of the interval, how frequent is the ECG, whether it is monomorphic or polymorphic ECG. So all those things we look into that, and also the axis. Now all these things are important because it helps us in prognosis of the patient. A simple VPCs and a complex PCGs, the prognosis is different. So what is the diagnostic criteria for making a VPCs? First of all, the VPC should have broad complex QRS, and there should not be any preceding P wave, mostly no preceding P waves. The T wave is usually in the opposite direction, and there has to be full compensatory pause is common, not always, but it's common. And then, as I said, you need to see the morphology of VPCs, whether it is RBBB type VPCs or LBBB type VPCs. So to evaluate that, we all know the ECG is the first thing to do. Now ECG will not only tell you about the VPCs, it will also tell you about any other abnormalities. For example, if your ECG is showing an old interval MI, then you know that this is probably a scar VPCs. If it's an old anterior MI and the VPCs are arising from LV, you know that this probably is a scar onset. The scar which is produced by the old interval MI is producing these VPCs. So it helps a lot in making a diagnosis also. It also may have to look for the prognosis also. Then all patients who have VPCs should have an echocardiogram. It's important to rule out structural heart disease whenever you have a patient of VPCs. Cardiac MRI we very frequently order because cardiac MRI can pick diseases like diseases involving the RVOT, ARVD, sarcoidosis, HOCM. You know, there are innumerable number of diseases where the structure of the heart is abnormal. Then certain diseases like, you know, sarcoidosis, tuberculosis, where you PET scan is probably can be ordered if you are suspecting it. Suppose a patient has got large lymph nodes, suppose the patient has a history of tuberculosis, suppose you find that mediastinal lymph nodopathy is there in the X-ray or CT, then PET scan probably will help you. So there are multiple classification of that based on location, you know, multifocal, unifocal, then based on trigeminy, bigeminy, couplets, triplets, you know. If you have 3 VPCs altogether, then what it means is triplets. When you have a triplets, we call it as a VT. Triplets are known as ventricular tachycardia. If this triplets or if these VPCs are present for more than 30 seconds, we call it as a sustained VT. If it is less than 30 seconds, we call it as a non-sustained VT. So there are multiple classifications. I am not going into details of that. So now the prognosis. Now prognosis till 1985, hardly people used to do it, so it was not considered as significance. Then probably in a CAST study said that if you try to suppress VPCs with drugs, it is harmful, it increases the mortality. Then in 1995, Amidron showed that if you decrease the VPCs, probably it helps in cardiac pumping power, it probably improves the mortality. And subsequent, most of the studies have shown that if this patient has a VPCs which is symptomatic, patients with VPCs with structural heart disease, if you subject them for an ablation, you probably do a lot of changes in mortality and morbidity. So what is the problem with the VPCs? Why we are unnecessarily chasing a patient of a VPCs? Now we very often see patients referred by us by you to us in OPD, and we see the patient and patient says, sir, मुझे तो कोई symptom नहीं है, आप तो बड़ी बड़ी बातें कर रहे हो, मुझे तो कोई problem नहीं है. What is the why we want to chase these patients of VPCs? We can leave it to them. When they have symptoms, let them come. Now problem ऐसा है कहीं देर ना हो जाए. Now why? Because these VPCs can induce LV systolic dysfunction. Over a long term, VPCs can induce LV systolic dysfunction, and once the LV systolic dysfunction sets in, it is reversible after an ablation, but it becomes a problematic to the patient. Sometimes a benign ECG, what you are seeing in the VPCs, what you are seeing in the ECG, can have an underlying VT in probably in the Holter. So it is important to chase these patients, especially patients who are marathon runners, especially patients who are very active, patients who are going to regular gym. Make sure they are not left alone with VPCs in the ECG and they are properly evaluated. So how to prognosticate this VPCs? So it's based on also the burden. So there are multiple definitions. Some people say more than 20% in a day. If there are VPCs, then it is significant. Some people say if more than 10 per hour in a patient who is non-ischemic heart disease. Somewhere it is written that if more than 30 per hour in a structurally normal heart, it is considered as significant. So other factors, for example, interpolated PVCs, longer duration of palpitations, broad QRS, epicardial PVCs, other variable coupling interval. As I said, coupling interval is important. So all those things, suggest that the VPCs are not benign. They need to be treated, or at least they need to be evaluated. There's a risk scoring factor. I'm not going into details, but we very frequently use this scoring system whenever we see VPCs. That is excess, burden, coupling interval, and ventricle tachycardia, runs of VT in Holter. So again, the prognosis, whenever you see whether these patients will have chances of VT or not, the important is you need to see the coupling interval. Coupling interval is actually an interval between a preceding normal beat and a VPCs. Now, if there's a variable coupling interval, the patients have poor prognosis, there's a chances of things going wrong. So then also you need to see the, if possible, patient is a case of suppose ischemic heart disease, you need to see the cardiac MRI. If you see a lot of scar, there's an old interval MI, old inferior MI, old surgical scar, then these, of course, these patients are having high risk of developing, VT in future. So important is when to treat. Now, if the patient has symptoms and it's correlate with the rhythm, then of course you need to treat it. Patients with low ejection fraction, low LV functions need to be treated. Patients who have a triggered VT-VF in Holter from this VPCs need to be treated. If a patient is on biventricular pacing, CRT-D and all, and if you find that this biventricular pacing is getting compromised because of VPCs, these need to be treated. And then of course, as I said, if the patient has got high-risk features of VPCs, for example, variable coupling interval, for example, very broad VPCs, now these are the patients who probably need. Patients with very high frequency of VPCs, more than 20% in a day, then of course these need to be treated. So management, of course, it's you need to manage them in multiple ways. Sometimes, just reassuring the patient is enough. You need to take care of lifestyles, for example, control BP, sugar, weight reduction, take care of anxiety, smoking. There have been a lot of this thing about you stop coffee. But I think recently the coffee is outdated. You can have coffee without any problem. I'm sure it is not involved. But we used to scare our patients, ज़्यादा coffee मत पियो. Sir, coffee नहीं पिए तो क्या पिए? Patient पूछता था. अभी nowadays I think it's all outdated. You can have coffee. Of course, not too much. You can have other diseases because of that. So, but VPCs are not very much related to taking at least 2 coffees or 3 coffees a day. So medical managements involve beta blockers and calcium channel blockers. So diltiazem, verapamil is the CCBs which are used to treat this patient, especially the RVOT types of VPCs, frequent VPCs. You can have flecainide, but thing is the patient should have a structurally normal heart. That is important when you use flecainide. Make sure you see the QT interval before you start flecainide. Then of course the codron is our old friend for many decades which we are using it. Use it carefully, look for the side effects. First read about all the side effects of codron, then only you start it, and make sure you observe these things when this patient comes to you for follow-up. Then of course you can have ablation therapies where various new probably things are coming which our fellow colleagues will be talking about, ablations in various type of arrhythmias. Now, sometimes we have an inflammatory cardiomyopathy, for example, sarcoidosis, where you need an immunosuppression, myocarditis. Then all those things, steroids and all those things need to be used. Certain channelopathies, make sure you avoid drugs which can precipitate VT, prolonged QT, short QT syndromes. Brugada syndrome is also considered as a channelopathy. So some people may need an AICD. So based on the diagnosis, structural diagnosis you make in the cardiac MRI or your clinical diagnosis, the role of AICD is well documented. Then the electrophysiology study. So I'm sure you can see this. So very simple. There is a flow diagram. But what is important is if you have a patient with low ejection fraction, if the VPCs are less than 5%. And symptoms are present, you can add drugs, antiarrhythmic drugs, or you can advise. See, nowadays our treatment of choice also depends upon what patient want. Now, suppose I have a patient who has got selected for a major something, his career building thing, and he comes with an VPCs, and we want to get rid of VPCs. He wanted his VPCs should be cured so that his next ECG don't show any VPCs. Probably I may offer him ablation. Isn't it? So it also depends upon. We had recently one patient who has absolutely asymptomatic, but his ECG showed few VPCs. We started him on medications, but they were very, very sure that they want an ablation. They wanted to get rid of this. And the medicines, antiarrhythmic drugs also, if you see, most of them, other than the beta blocker and CCBs, they are not a simple drug. They are toxic drug. For example, flecainide, maxilitine, codron. So it also depends upon patient choice whether they want an ablation or they wanted a medicine to be taken or not. So if the patient has got more than 10% of VPCs, consider ablation, and if it fails or a patient declines, then of course you continue with antiarrhythmic drug, and you can replan it with a special 3D mapping ablation. So similarly, if the patient has got normal LVEF, probably you can be a little slow in advising them, EPRFA. If the patient has got symptoms, you can treat them with antiarrhythmic drugs and follow up. If they don't have a symptoms, if the frequency of VPCs is very less, you can just reassure them and tell them to improve their lifestyle. But yes, if they are more than 5% with and the patient has a lot of symptoms, of course you can offer antiarrhythmic drugs and ablation. So the treatment of VPCs, first of all, assess whether what is the frequency of VPCs, assess whether these VPCs appear malignant to you by the criteria which I said, like broad QRS, coupling interval, frequency, the origin. Assess for the structure of the heart by doing an echo, if possible do cardiac MRI. If you are suspecting inflammatory disease, get a PET scan. And then based on all the reports, if you find that patient is symptomatic in spite of medications, offer them EP-RFA ablation. So, and on top of that, we should also keep in mind the need for AICD, that is automatic intracardioverter defibrillator, which is probably a life-saving device. So I'm not sure how much you gathered it. It is a long, probably a difficult arrhythmia topic. But to summarize it, PVCs are very common, impending epidemic in era of new gadgets, because more and more gadgets we have, more and more we diagnose it. PVC can cause VT and LV dysfunction, so don't neglect PVCs. Make sure it is properly evaluated. Risk assessment is the utmost important when you see a PVCs, and major management include lifestyle management, catheter ablation, and antiarrhythmic drugs. So thank you very much.
Thank you, Dr. Brajesh. It was a very informative talk. Just few comments from me. So, in my practice, first thing I note what is the age of the patient. If patient is very elderly, more than 80 years of age, and asymptomatic, even if there are frequent VPCs, we tend to treat it conservatively. I want to have your comments also. Then if patient is younger and there are very frequent VPCs, we further evaluate. Definitely echo is must. Holter monitoring, 24-hour Holter monitoring, I think it is very informative. It will give the further burden of VPCs, and we can decide the further treatment.
Yeah, so one thing I've learned in my career is, as a doctor, I cannot decide the age of the patient. It's the relatives who says. Some relatives comes and says, my father 80 years is a young, he's very useful to me. Please treat him in the best of your knowledge. So for me, treating the patient based on age is also related to how you treat the relatives, how the relatives comes up with. We had patients who had 90, 95 years, came with MI, and the relatives wanted us to do interventions, and we did, and we realized how fruitful was the intervention. When the patient comes to you, walking in your OPD and say, sir, abhi bahut acha lag raha hai, papa bahut अच्छे हो गए, sir, thank you. So my evaluation will not go based on the age of the patient. I am going to evaluate both these patients very aggressively if the relative wants. Now, if you come and say, mere papa budde ho gaya, abhi kuch mat karo, I am not going to do it. But if you say, sir, evaluate my dad well, I am going to do everything possible in sitting in Apollo, where patient don't come as, walking most of the time. It is almost referred. So I am going to evaluate the patient, make sure the Holter is ordered, echo is ordered. If I feel there is a need to do an MRI, I am going to order MRI. Because there is a possibility that I may pick something which gets treated with a small medicine. It may not be an ablation, may not be we are going for a big surgery. May be possible that you miss a sarcoidosis, you miss something which probably ARVD, and we are no one to decide what is the lifespan of a patient. 80-year-old patient can have another 20 years. So we are reducing his 20 years. A 30-year-old man can have only 5 years. Maybe he die with an accident with this thing. So I am not the one who will decide. It's the relatives and the patient to take a call. So that is why if you see my presentation, age is not there.
So relative has become absolute indication.
Yeah. So age is not there. I feel I am still young.
No, Dr. Vijay, I am saying whether age itself is a cause of frequent disease.
So, with the age, probably you need to rule out ischemic heart disease. Now, you have, of course, in younger age group, Tamir rightly said, in younger age group, we are aggressively to find out channelopathies, ARVDs, HOCM. But with over a period of time, when the patient is in 7th decade or 8th decade, probably ischemic heart disease where we are aggressively in finding it out. But yes, evaluation need to be done. Sometimes, sometimes you neglect and patient, when the relative calls you and said, Papa to suddenly death ho gayi, aapne to treat hi nahi kiya, hum to laaye the aapke paas. So all those things need to be, stressed upon. The reason for VPCs can be different in younger, as he rightly said, can be different in elderly, but evaluation both of them needed. I am aggressive in evaluating both of them. Because there can be small anti-anginal can prevent his death. You start an NG spunt here, 2.5, echosprin AV, and do a cardiac MRI, echo, and you leave, let the ball be in patient's relative court. Why you want the ball to be in your court? Why you want to say, I don't want to evaluate, your papa is 80 years? No, let him tell, I don't want to evaluate, my papa is 80 years. That is important. So I think this is little away from the academic, but this is what we should do in OPDs. Let the relative decide.
So one more question. See, Papa is 80 years old, but the drugs are not properly controlling the disease, and he has to go for ICD. Whatever is life of that patient, because it's going to be always very painful every time when the ICD tries to overcome VPCs.
So ICD is not to prevent VPC. ICD is to prevent sudden death. So first aim should be to make sure the cause of VPCs to be found, whether the patient is symptomatic because of VPCs to be found, and the ICD comes only if you feel that the patient can have sudden cardiac death because of that. So what is your question like? Why we should not do ICD in 80 years?
No. You should do it. How comfortable Papa might think like the ICD instead of ICD. Death would be better, Every time
So
to give him pain.
Here the patient has taken it in that. So we should write it on our papers. Patient decided death will be better than AICD and just leave it. You cannot force patient for an AICD कि अभी death नहीं करने देंगे तुम्हें मरने नहीं. See, after all, who will pay? Papa will only pay, or the son will only pay. So without payment, AICD is not possible. It's a costly device. So the will of the papa as well as their kids is very, very important when you decide for that. In this scenario, like what madam said, the patient is not willing for an AICD, maximize your medicines. As I said, we have something like, find out if it is ischemic heart disease, add antiplatelet, add beta blockers, add calcium channel blockers, add anti-ischemic medicines. You can have nitrates, nicorandils, trimetazidine. then if Papa is willing for an angiogram, do an angiogram, find out what is happening. Is it a coronary artery disease? And many a time, madam, by seeing the VPC's morphology, you prognosticate. As I said, VPCs, if there are 1 or 2 VPCs that arising from RVOT, you don't need. But suppose Papa had an old history of MI and the VPCs are frequent arising from that scar. Now that is the patient where you feel sudden death is more important to prevent. That is the time when you advise AICD. So we are also very sensitive. We know if we advise AICD to a patient who does not have those symptoms, most of us usually will advise AICD once we have a recorded VT or we had an averted sudden death. Patient has CPR this. Because we know the moment you advise AICD to a patient, a 15 lakh device, he will see the next cardiologist in the next chamber for a second opinion.
Correct, madam. Madam is saying that every time you have a VPC, you get a shock. It's not like that, madam. Anytime you get a VT, you get a shock.
Yeah.
It's not that with every VPC you get a shock.
It's only when you have a sustained, yes.
So if you have a sustained VT, only then you get a shock. It's not that every VPC you get a shock. So that is something that you have to realize.
Myocardium is so much damaged that every time if it's getting shocked, that means it's getting VTAG.
It's a VTAG.
Yeah.
VTAG gives shock, not the VPC.
Yeah.
So that is something that every government often hold up.
Yeah.
What is the burden? What is the PI? How many VTAG, how many STDs is having or NSTDs is having? So that is what guides us to have an ICD.
And most importantly, whenever we write in, whenever we put away ICD, our main aim is always to prevent the shock also. So we will give medicines also to prevent the shock. So AICD is always to prevent the last, मतलब अभी जा रहा है मरीज तो बस अब कुछ तो है तो वो बचा ले. So that is for AICD. It is not like कि मजे लो shock खाओ.
Can I just add something? Madam, I agree with your reservations towards ICD, but this topic was not towards ICD. So, sir, as he rightly, he's never stressed on ICD in all his presentations. Yes. All throughout, he was talking about medications, he was talking about ablation. Yeah. And if you end up putting an ICD, you already continue the medication for one. There is something called an anti-tachycardia pacing, which is there in all the ICDs nowadays. So, not all ventricular tachycardia needs shock. They can be treated with something called as anti-tachycardia pacing, which is not felt by the patient. There are very few instances nowadays because the ICD technology has gone that ahead that they don't need shock. And so the threshold of an electrophysiologist for such patients is very low while asking for ablation. Because once you get a shock, getting those, so we call it a phantom shock. So the patient feels every time he's getting a shock, even though there is no shock. So as sir rightly said, we try to avoid any shock. ऐसा नहीं कि ICD ज़्यादा मतलब कल से shock चालू होगा. No. If the patient is completely controlled on VT only, we put an ICD. Otherwise, we don't go for ICD till the time the VTs are controlled.
And we have to program the AICD in such a way that initials, we have anti-tachycardia pacing. So you can program it in such a way that if VT happens, this will be the first thing to tackle. The shocking, even in AICD protocol, is the last one to offer to the patient. So most of the time, patients settle it down, but yes, we do a lot of shocks. If the continue to have a shock, madam, in spite of having an AICD, we had patients. Then we have certain things like, can do sympathectomy. There's something known as sympathectomy which we offered to a patient. We did one sympathectomy patient for post-VT. Patient used to have recurrent shock in spite of anti-tachycardia pacing. He was getting 1 or 2 shocks per month, but the shocks were very, very painful, as you rightly said. So, if it doesn't shock, he was going to die in spite of on Cordron, on Maxilitine and all those things. Still the patient used to have shock. So we did one sympathectomy patients. Post sympathectomy, he had once in a year 1 shock. That's all.
Yeah. Good morning. Thank you for your lucid presentation as always and very fruitful interactive discussion. I just want to know, see, most of the VPCs are benign, right? And age has been discussed, I won't discuss that again. Caffeine is out, as you said. Alcohol still contributes, anxiety contributes, but then lifestyle modification we always advise. And because most of them are benign, but anytime they can progress to malignant, right? So how frequently should we chase them? If all the investigations are normal, no structural heart problems, but still they can turn into malignant anytime. So how frequently should we call them?
For a very infrequent VPCs, you don't need to call them specially for anything. Suppose you are also his diabetes, hypertension. Whenever the patient is scheduled for next visit, you call them and if possible get an ECG. But yes, do ask them that they have symptoms of any VPCs. Did they have any syncope? Did they have an episode of palpitations? Did they have an episode where they felt like almost going to die? So all those symptoms can be asked in the every visit, but only for infrequent. Once you have evaluated Holter, 7 days Holter, we have event loop recorder, you have cardiac MRI done, echo done. If you find it is this thing, there's no need to separately call them only for VPCs. Call them for...
People without comorbidities, when they go for regular health checkups, most of them are detected with this.
Yeah, we can tell them for a lifestyle modification, maximum you can use is a small dose of beta blockers.
And when to call them?
6 months, 1 year, or if any symptoms in between. But that is only when you have ruled out everything, madam. Sure. Thank you very much. Thank you for patience.
Thank you. So, I would request the panelists to felicitate Sir for the good speech. Thank you all. Our next speaker will be Dr. Rahul Gupta, Chairperson Dr. Anup Mahajani, Dr. Prashant Pawar, panelists Dr. Akshay Chalani, Dr. Vishal, Dr. Manohar, Dr. Madhvi Thuge. Thank you.
I think Brijesh has given an excellent presentation, and we were talking about the age. I tell you, we had a 90-year-old lady, telling you over there, no, that Mrs. Sushila, she's no more with us. At 1991, heart failure, LBBB, EF 25%, 35 kgs weight, but full of life. And she said, I want to live more, I want to write more books, and please make me well, whatever it needs. We were a little hesitant to tell her that, actually you need a CRTD as the management, but for your age, do you want to really go? She said, yes, I want to go. She lived for 4 more years. EF completely improved to normal, and I think she did well. So age is just a number, and I think Brijesh has rightly pointed out that you need to discuss with the relatives, find out, discuss with the patient, what do they want to do, and I think they can have a meaningful life. So I think while they are arranging, I have certain trophies. Can you just hold on? So these are some international trophies. I will keep it because it's going to be interactive. Should I keep it over here? Yes. So these will be given to people who are answering, who are appointing themselves when I am teaching, so that we can have some interactive. You guys have to be judged who is answering the best. You can, if you answer, you can take it. Yes. Lights, let me just switch off the lights. I think, thank you Sanjeev for giving me this topic. This is an extensive topic. I'll try to cover, he said, complete in 10 minutes. I'll try. So, this is atrial fibrillation. And what is atrial fibrillation? You have got you can have fast ventricular rate. If you treat with treatment, you give AV nodal blockers, the ventricular rate can become on the lower side, but there are no PVs. See the irregularity between the RR waves, and there are no PVs which are there. Now, so why do we need to understand that atrial fibrillation is so important? Because if you look at the statistics, there are 50 million estimated individuals of AF worldwide in 2020, and it's going to double by 2030. Increased risk of death, stroke, dementia, MI, SCD, heart failure, CKD, everything is increased with atrial fibrillation, and therefore it is important that we understand and we try to treat this atrial fibrillation. Now there can be various kinds of atrial fibrillation, paroxysmal, persistent, permanent atrial fibrillation, I will define, and there can be other classification, valvular and non-valvular, because your treatment strategy will depend upon what kind of atrial fibrillation this patient is having. So this is a classification 2013 by American Heart Association. where like heart failure we define at risk for heart failure. Who are patients who are at risk of heart failure? Obesity, lack of fitness, hypertension, sleep apnea, alcohol, diabetes, genetics, male sex, age. Then pre-AF means they are getting frequent atrial ectopics, short run of atrial tachycardia on Holter and all. And then we have paroxysmal AF, where the AF terminates within 7 days. Persistent AF, it takes more than 7 days. Long-standing persistent AF. Permanent AF, you have lost the hope of treating these patients to rhythm control. You are just trying to control their rate. So these are the AF kind categories which are there. Patients can present in various signs and symptoms. Most of the time AF can be asymptomatic, incidentally detected, but they can have palpitations, breathlessness. Sometimes they can develop complications like stroke and heart failure. That could be the first presentation, and their quality of life can get impacted because of the heart failure. So now, how do we diagnose? We need an ECG for atrial fibrillation for sure, because that's how we will diagnose that this is an atrial fibrillation. And you might, if suppose they have incident, they have episodic episode. It's not all the time, but they are getting palpitations. How would you evaluate? You might have to go for Holter monitoring or extended loop recorder or internal loop recorder to find what kind of arrhythmias, or taking the ECG during the event is the best way. If they are having symptoms, advise them to take the ECG during the event. Then you have to evaluate, you have to do their blood profile, blood chemistry, thyroid functions, CBC, RFT, LFT, electrolytes, all these have to be managed. Now, from here onwards, please remember, because that's how you are going to get those trophies, because this is education and then there is a quiz. So, what are the goals of treatment in atrial fibrillation? So, a heart rate is irregular. You want to make it regular. You want to make it sinus rhythm. This is called as rhythm control. Versus just controlling the rate. So, the ventricular rate you want to decrease. You want to get it around 70, 80 or whatever at the lower side, because otherwise in atrial fibrillation they can have very fast ventricular rate. So, two approaches. Rate control, where you just control the rate but AF continues. Versus rhythm control, where you want to control the rhythm of the patient, get them back to the normal sinus rhythm. Our try should be to get them into rhythm control if possible. If it is possible, get rhythm control. Otherwise, if it's not possible, then try to get a rate control. Second, very important goal of treatment is to prevent a stroke. Atrial fibrillation is responsible for cardioembolic stroke. They account for about 40%, various kind of cardiac related reasons, and a lot of them are because of the atrial fibrillation. And therefore, after a stroke, we do a Holter monitoring. Their ECG comes out to be okay, but you want to find out whether they are having any kind of arrhythmias, and then therefore you order them to do a Holter test for extended period of time, so that you can pick up any episode of atrial fibrillation. Because if they have atrial fibrillation and they have a stroke, antiplatelet regime is not going to help them. You will need anticoagulation for them. So we have two kinds of blood thinner: antiplatelet like aspirin, clopidogrel, ticagrelor, prasugrel, and anticoagulants like warfarin, acetylcholine, which are vitamin K antagonists, and NOACs like dabigatran, apixaban, rivaroxaban. These are the three anticoagulants which are available. Then symptom relief. Symptom relief, if they have developed heart failure, treatment of the heart failure, controlling the rate, all those things would be a thing. And treating the underlying cause, if they have pulmonary disease, hypertension, thyroid disorders, all those things. Now, what are the rate control strategies? We discussed pharmacological agents. So, which are the pharmacological agents most commonly used for rate control? These are AV nodal blocker drugs, beta blocker. In calcium channel blocker, we have diltiazem and verapamil. Okay, these are available and these you can use commonly. Then we have digoxin. Suppose somebody has got heart failure and somebody has got atrial fibrillation with fast ventricular rate. Digoxin is also a heart rate controlling measure. Then we have non-pharmacological intervention. Okay, so pharmacological interventions are not helping these patients. You have given all possible medications, rhythm control is not possible. Now what do? You can do AV nodal ablation. So you block the AV node completely through the interventional procedures like the catheter, when we do ablation like EPRFA, and then you implant them the pacemaker to get the ventricular rate at the desired rate. You are getting my point? Rate is not getting controlled with medications. Patient is very symptomatic and you want to use a non-pharmacological treatment, so these are there. Now what are rhythm control strategies? We have pharmacological options, antiarrhythmic drugs. Most commonly used antiarrhythmic drugs is amiodarone, which we commonly use. We can use sotalol. Then we have flecainide and propafenone, which are like pill in the pocket kind of treatment. Now when there is a structural heart disease, the safest is to give amidron. In a structural heart disease where the heart is damaged, we avoid flecainide, we avoid propafenone in these patients, but we can give this thing. Second is rhythm control, you give a shock. You give a cardioversion. You admit the patient, rule out any kind of clot inside the heart by doing either a transesophageal echocardiography, or you give anticoagulation for about 3 weeks, and then you do a cardioversion so that you prevent the stroke and you can get them back to the rhythm normal. So this is the second method. What is the third method? Is catheter ablation. So we have stalwarts around here, and we have a high-end 3D EP system. Wherever it is available, it's available over here, where you can do a AFib ablation to get these patients back into the rhythm who are symptomatic, who are in heart failure. Every time they go into the fast heart rate, their heart failure is precipitated, they are getting recurrent admissions. You need to control their heart rate. Stroke prevention, how can you do? Anticoagulation therapy. We discussed about the vitamin K antagonist, warfarin and acetylcholine. We want to keep the INR between 2 and 3 with frequent monitoring. But better is to give direct oral anticoagulants or the NOAC, the levorexaban, the apixaban and the dabigatran. We will discuss about their doses, but they are the best one. They are better than warfarin to be given, but they cannot be given in valvular AF. Therefore, that differentiation is important. What is valvular AF? Valvular AF is not all valve diseases. Valvular AF means when they have a mechanical valve, the mechanical metallic valve, it's a valvular AF, or when they have moderate to severe MS. MR is not considered as valvular AF. AS is not considered as, suppose somebody has AS or AR and atrial fibrillation, it's not considered as valvular AF. If they have moderate to severe MS and or they have mechanical valves, then you cannot use NOACs or DOACs. You have to use only vitamin K antagonist. So it has a role. Then we should use 2 scores. Chat-West score. Anybody aware about the Chat-West score? Okay, it is to decide whether this patient needs anticoagulation or not. What do you think? Does aspirin have any role? If the Chat-West score is 0, 1, do we want to give aspirin? It is outdated. We don't give aspirin anymore. Either you don't give any treatment, or if it is the score is high, that means 1 for a male or 2 for a female, then you give oral anticoagulation, either vitamin K antagonist or a DOAC. Please, I am telling you very emphatically because then the quiz is going to begin. Importance of patient education and adherence is very important in preventing this thing. And one of the device is LA appendage closure. When you are in catch-22 situation, LA appendage closure is something which is going to be helpful. Anybody aware about LA appendage closure? So let's look at Chest-West score and Hasbled score. Chest-West score is to decide what is the risk of stroke, and Hasbled score is the score to decide what is the bleeding risk in this patient. Okay, when you are giving anticoagulation to prevent a stroke, you don't want to create bleeding issues in your patient. That is your aim. So how do you balance this strategy? So we will look at the Hasbled score. So please revise, because after this slide we are going to start. So C stands for congestive heart failure, 1 point. Hypertension, 1 point. Age more than 75 years, 2 point. Diabetes, 1 point. Stroke, previous stroke, 2 points. Vascular disease, 1 point. Age 65 to 74, 1 point. And female category, 1 point. Total 9 point. If there are 0 points, no anticoagulation is needed. If there are 1 point, anticoagulation is recommended in males only. And if there are 2 points, oral anticoagulation is recommended both in males and females. Everybody got this? Congestive heart failure, hypertension, age, diabetes, stroke, and the vascular disease. Okay? So we are going to calculate in all our case scenarios. Now this is Hasbled score. So it's a logical thing. Hasbled score means it is telling us the risk of bleeding in these patients. Anybody hypertension more than 160, abnormal liver function, abnormal renal function, stroke history, bleeding prior major event, labile INR, elderly. So what is actually, if you look at this score and if you look at Chest-West score, what is actually a risk factor for thrombosis is also a risk factor for bleeding. So then you have to balance it out. Are you ready? Are you ready? Okay, people are ready. They are interested about this topic on. So let's begin. Case scenario 1, 56-year-old male. Okay, remember everything, whatever I am telling, because somebody has to raise their hand and answer, and judges will decide whether no risk factors. Okay? Start calculating the chat score, chat score in this patient. No risk factors. Presents with intermittent episodes of irregular palpitations. So they say it's irregular rhythm, stays for half an hour, goes away. How will you approach? What do you want to do? First test, what do you want to do? ECG, great. So ECG is normal because when he came there was no episode. Okay? Then what next? Fantastic. So you do a 7 days Holter and then you find one episode of AFib has been detected. Now, what is the approach? Which medication do you want to give to this patient? For stroke prevention, what do you want to give? For stroke prevention, anticoagulation strategy. What is the chest score? 0. Do you want to give anything? Great, yeah. I don't need to take this. I don't know how will I distribute. Everybody is answering. Echo is normal, so no structural heart intervention. Blood tests are normal. Okay. Which medicine? You can give a small dose of beta blocker, symptomatic relief, because this is a kind of paroxysmal AF. Anticoagulation on chest score doesn't need anticoagulation. And I think lifestyle changes like quitting smoking, alcohol, stress reduction, caffeine, I think Rajesh is oriented is out, but they can have coffee. Because वो पूछेंगे ना फिर सब कुछ नहीं ये कुछ नहीं ले सकते तो what is the life? You can take caffeine. So this is kind of low rate of fibrillation, younger age, less than 60, no underlying cause, usually not much symptom, normal heart structure, no associated comorbidities. About 50% of all patients with paroxysmal AF and 20% of patients with persistent permanent AF have structurally normal hearts. And rhythm monitoring tool which all of you told, Holter can monitor for 1, 7 days, 14 days, ELR for longer period, you can put patches these days. These are external loop recorder, and sometimes you can use ILR. I'm just telling you for palpitations which we are not able to diagnose once in 3 months, 6 months. You can make a small cut, OPD basis procedure, you insert a pen drive kind of thing which is internal loop recorder, and you can record for 3 years. So if they have symptoms, you get them back, evaluate what has happened, and you will be able to diagnose. These are something in this patient: obesity, weight control, physical activity, alcohol consumption has to be stopped, smoking, and if they have any of these risk factors, they need to be controlled. These are AHA guidelines, all class 1 recommendation to reduce weight, exercise, cigarette smoking has to be stopped. Special to be too reasonable to screen for OSA given its high prevalence in patients with AF, although the role of treatment of sleep disorder breathing to maintain sinus rhythm is uncertain, but they should be evaluated because obstructive sleep apnea has been associated with atrial fibrillation. Patients seeking a rhythm control strategy should minimize or eliminate alcohol consumption, and caffeine abstention does not prevent AF episode. It may reduce symptoms in patients who report caffeine triggers. Caffeine trigger ho raha hai, then only you need to stop the caffeine in these patients. You can suggest them, otherwise not needed. Case scenario 2. Same patient, now 58 years old, 2 years, comes with palpitations for last 2 hours, ECG shows AFib. Still no hypertension, non-diabetic, echo is normal, blood tests are normal. How will you manage? What do you want to give? AFib is continuing. What do you want to do for the rhythm control? You want to go for rhythm control or rate control? Rate control acutely, but finally you want a rhythm control because it's a structurally normal heart. So rate control you can do. Sometimes with diltiazem, beta blocker, sometimes it can reverse. Suppose the patient has come into the emergency, you give a beta blocker or a diltiazem, actually it will convert the rhythm back to the normal sinus rhythm. Otherwise, you can think about antiarrhythmics. So which antiarrhythmic you want to give in this patient? Structurally normal heart, youngish. You can use a pill in the pocket approach. Flecainide and propafenone can be used. Amedron is the most commonly most known antiarrhythmic. Can be started in this patient. Any role of anticoagulation? Only Ambirate sir is answering. I think he will take all the chocolates. Cardioversion. Do you think cardioversion is an option? Cardioversion is also an option. I had a patient, international guy. He used to have AFib once in a year. He came to me in the OPD, said, "Sir, I have developed palpitations. It is irregular. I want a cardioversion." Because every year he comes, he takes a shock, he doesn't take antiarrhythmic. So these are the patients. There are the patients who can just take, it's a very paroxysmal AFib which doesn't need once in a year episode. This is one such patient because he was all well read. I think he was a European guy. and he came and asked for cardioversion. We did cardioversion and then he left. Anticoagulation is it needed? I think Chester score. What is the Chester score now? No hypertension, no diabetes, structurally normal heart, 0. So no need of anticoagulation. So paroxysmal AF, occasional attacks that are well tolerated do not necessarily require treatment. Beta blocker as first line therapy if troublesome and if associated with ischemic heart disease, hypertension and CCF, you can use beta blockers. They reduce the ectopic firing that normally initiates the AF. Class 1C drug, as we discussed, propafenone or flecainide, also effective, but they are contraindicated if there is a LV dysfunction. Everybody got it? Great. The same patient is 62 now has recurrent symptomatic episodes of atrial fibrillation. He is hypertensive and diabetic both. Are you calculating the Chester score? You are seeing that AF is a progressive disease. It's progressing from something very benign to something more persistent. What are the options? Rate control, rhythm control, antiarrhythmic versus EPRFA. You want to refer to us and send him for the ablation because he's having paroxysmal AFib. Very good response rate in paroxysmal AFib. So EP guys will speak about it, but it's a good option. Patient chooses antiarrhythmic. Nobody wants intervention, so they choose antiarrhythmic. You start on amiodarone. What will you monitor and what frequency? Can somebody answer? If somebody is on chronic amiodarone therapy, what are the things? And LFT and pulmonary function test and dermatology. So you can have side effect. What should be the frequency? Thyroid function test, LFT every 3 months. SGOT, SGPT and TFT you can do because hypothyroidism is more common. Hyperthyroidism can also occur. If there is a liver function, you might have to reduce or temporarily stop. PFP because they can develop interstitial lung disease. Every 6 months you should monitor. Annual checkup, as Dr. Charan rightly mentioned, corneal deposit, keratopathy can develop. So refer to ophthalmologist once in a year, and sometimes they can have a dermatological reaction. They can have photosensitivity. You should be aware about it. Okay. So this is the frequency, TFT, LFT, PFT option evaluation. Will you start anticoagulation now? What's the Chester score? He's 62. He's hypertensive. He's diabetic. Male doesn't have a risk factor. So 2. Madam gets the chocolate. Because hypertension, diabetes, age is less than 65. So we get the score of 2, but the patient deserves anticoagulation. Which anticoagulation would you like to use? Which NOAC? Any one of them. So which anticoagulation? So anticoagulation choices, warfarin or acetylene, we discussed. It is the only choice for valvular AF, moderate to severe MS or mechanical valve. This qualifies for valvular AF. Again a revision. NOACs, apixaban is 2.5 to 5 mg BID. There is the ABC criteria for apixaban: age more than 80, body weight less than 60, and creatinine more than 1.5. 2 out of these 3 criteria, if they match, you give 2.5 mg BID. So if a person is 80 years of age, one criteria is full. Body weight is 70, creatinine is 1. Will you give 5 mg BID or 2.5 mg BID? Age is 85. Age, only one criteria. You have to meet 2 criteria to reduce the dose to 2.5. Age 85, very old. The creatinine is 1, which is okay, and the weight is also 65-70 kgs. 5 mg. Now this patient's creatinine on follow becomes 1.5. GFR is reducing. Reduce it to 2.5. Patient loses weight. Weight is now less than 60 kg. Reduce it to 2.5. So this is what you have to do. Don't worry. Use evidence-based approaches to treat your patients. Don't underdose them because you will not give adequate protection. Rivaroxaban 15 or 20. Usually it is 20. Renal dysfunction you can make it 15. You are giving with other antiplatelets therapy, you make it 15. Dabigatran again 150 mg BID. Again age, and if you are giving with other antiplatelets, you make it 110. Unfortunately, patient develops side effect related to amiodarone, needs to be stopped. What is the option? Now this patient is progressing. Now developed the side effect to amiodarone. What do you want to do now? Ablation. Fantastic. I think you guys have learned it. So we go for catheter ablation when antiarrhythmic drug therapy is ineffective or causes side effects. It is used to disconnect the pulmonary veins from LA electrically, preventing ectopic triggering of AF. Lines of conduction block can be created within the atrium to prevent re-entry and prevents AF in approximately 70%. So you are sending for a 6 lakhs procedure to us. We have the high-end 3D PRFA machine. We have the best of the electrophysiologists. But remember, despite that, 70% only is the success rate. They might need repeat procedures sometimes. Be fair to your patient, be transparent, tell them this is the statistics. If they are okay with it, go ahead with it, because that's how they can get tremendous benefit. Associated with the risk of cardiac tamponade or embolic stroke, so maintain the heparin, maintain the anticoagulation, rule out any kind of LA appendage flow. So this is the second last scenario, because the patient is going to come back to you, develops tooth pain or develops a cataract, because he is progressing, he is becoming older, needs a tooth extraction or a cataract surgery. He is on a blood thinner, referred to you for management. How will you manage? How many days before the procedure you will stop? Go ahead, somebody raise your hand and tell me. No, we have to stop. We have to stop because this patient will bleed otherwise. So we have different answers. I'll give you a scientific AHA 2023 recent recommendation. So apixaban 1 day if it's a low bleeding risk, 2 days if it is high bleeding risk. Dabigatran if the creatinine is normal 1 day and then 2 days again same. Rivaroxaban again 1 day and 2 days. So low bleeding risk, creatinine is normal, whether it is apixaban, whether it is dabigatran, because these are the three commonly used: apixaban, dabigatran, and rivaroxaban. 1 day for low risk and high bleeding risk, stop for 2 days. Very clear. If there is a creatinine which is on the higher side, the creatinine clearance is low, then you stop for double the time, 2 days or 4 days. And if the patient is on warfarin, you want to get less than 1.5, it will usually take about 5 days to get it below 1.5, but check the value and then send these patients for anticoagulation. This is the anticoagulation strategy management in these patients. Case scenario 5. 66 develops an MI, undergoes angioplasty. What should be the blood thinner strategy? Which antiplatelets you can use and which one you will not? Which are the antiplatelets you should not use? Because you need to give anticoagulation also to this patient. Prasugrel, because prasugrel in combination with the anticoagulation will increase the risk of bleeding. Brilinta also we can avoid, but it has been used. The safest would be to use ecosprin, clopidogrel, and a NOAC in a reduced dose. So 15 milligram of rivaroxaban or 2.5 milligram. So anticoagulation in what dose? That is what. So in a very complex angioplasty, what would be the strategy? You use triple drug therapy, aspirin, clopidogrel and NOAC in lower doses for 4 to 6 weeks, followed by double drug like clopidogrel and NOAC for 1 year, and then just go on to anticoagulation. No antiplatelets are needed. But if it's not a complex angioplasty, simple angioplasty, not a left main multivessel bifurcation, you can begin with only 2 drug therapy in these patients, even after a week, and it is absolutely safe. We don't have to worry because we have to meet the thrombotic, balance the thrombotic and the bleeding risk, and followed by anticoagulation lifelong. Case scenario 5, after a year patient develops episodes of GI bleed whenever on anticoagulation. So anticoagulation must stop because patient said, sir, your medication is causing me the bleeding, what should I do? You stop the anticoagulation because every time you start he's getting bleeding. You change multiple anticoagulation, you said rivaroxaban has got higher incidence of GI bleed, you started on apixaban. So rivaroxaban has got a higher rate of GI bleed. Dabigatran has got higher incidence of GI discomfort, not GI bleed, GI discomfort. So you change it to apixaban. You tried everything but still bleeds. Then you stop and he developed the stroke. Then they say, doc, we heard about something which you did not discuss with us. This is wrong. We are in catch-22 situation. What did we not discuss with this patient until now? Is taking away all chocolates. What is the option? Option is LA appendage closure because we are in catch-22 situation. So LA is the site in the LA appendage which forms 90% of the clot. Most of the strokes are happening from there. So if you close it, you will prevent stroke. Contraindication to oral anticoagulation, high bleeding risk, difficult to maintain IR, poor compliance, difficult to manage the patient because of logistic problems. You close them. These are the LA appendage closure devices. This is how it closes. This is the catheter. We do is transcatheter wise. We go through the femoral vein, puncture the septum, go to the LA side. do it in half an hour, 45 minutes under a conscious sedation. Patient is ready to go home next day. This is how the LA appendage looks like, thumb-like impression. There are various morphologies of the LA appendage. These are different views on the transesophageal echocardiography. You close it, this is the catheter, this is the proper size, this is how you close it, and this is how you make a figure of 8 speech, figure of 8 knot, and patient is ready to discharge on the same day. After 3 months, this is how acutely it looks like. This is an animal model, and this is within 3 months it gets endothelialized, and patient can be off anticoagulation. So you gave aspirin for 3 months, and then you can be off anticoagulation, and these patients will be very, very happy. So the same patient undergoes LA appendage closure and is doing very well. He's off blood thinners. Thankful to you that you referred him to a team of Apollo doctors for this procedure, but the story doesn't end. Develops persistent AF, heart rate very high, resistant to medicine, develops tachycardiomyopathy, LVF drops to 25%. What will you do? Last. We have come to the last. Anybody? I discussed in the beginning. Anybody from the audience? What will you do? Somebody. We can't give all chapters to Charan. Anybody? Can somebody stand up and tell what will we do in this patient? Persistent high heart rate, not getting better with anti-arrhythmics. What do we do? Not AICD. AICD is not going to help. The last resort is AV nodal ablation. You ablate the AV node, so none of the impulses from atria, because atria is circulating at 300, AV node is not able to jam those signals, heart rate is persistently 160, so you ablate the AV node, you put on oral medical therapy, and you preferably put a pacemaker, preferably a CRT for cardiac resynchronization therapy, so that we can control the heart rate, LV ejection fraction. This patient becomes better, and he's very thankful. So I think I must end my presentation, because when I was looking into it, the management of AF can be continued for the entire conference, but I am leaving some discussion for the next time, like management of AF in elderly, CKD, liver disease, cancer, athletes, obesity, pregnancy, hyperthyroidism, pulmonary disease, sepsis, HF, HCM, WPW, post-cardiac surgery, reversal agents, etc. So there is so much. Thank you very much. So if there are questions, I'll be happy to answer. But one interesting fact about obesity is that, somebody who's gone a bariatric surgery, the NOAC may not be a good idea. I just wanted to give you this tip. So this all needs discussion. How do we manage liver disease, child A, B, C, CKD 1, 2, 3, 4, 5. So these all needs discussion. But I think we'll have another course just on atrial fibrillation, so that you become the best AF expert in the city. Thank you. Any questions or anything?
I have only question that determining to that every year it comes for cardiovascular. Every time you do anticoagulation, do the TE and do things of that. Just
no. So if the AF, so good question. If the AF is less than 48 hours, you don't need anticoagulation. You don't need to do a TE. So suppose somebody is aware. He was aware. This is only one patient in my entire career who just came and said, "Doc, we do me cardiovascular. No, Ametron and all."
Patient thinks of doing cardiovascular whether that like it the pulmonary artery or doing appendix. Every year you give a shock to him. It makes sense. What is the science behind that? Every year you do a cardiovascular instead that like it the pulmonary veins or appendix.
That's an option. So that's an option. But this guy, well-read, again like a Westerner who is well-read about his disease process, and he says, "I get once in a year or once in a while. I like to get a shock. I get better." So this was one case I have seen who comes directly and he says that I want to do that. But all these options are there. Doing this paroxysmal AF, if it's recurrent and symptomatic and very much, they can do pulmonary vein isolation through radiofrequency ablation.
So even pharmacological cardioversion like Evitlet does what does.
Yeah, so that pill in the pocket option is also good. As I discussed about, you can give, so they keep this propafenone or the flecainide and they can just pop it. And within some time, this is called as chemical cardioversion. We have electrical cardioversion, we have chemical cardioversion, we have radiofrequency ablation to rhythm. So I discussed in the talk that we can give these two pill in the pocket approach, where whenever they get AFib once in 3 months, 6 months, they just put the pill and it gets better. Yes, sir, please go ahead.
Now, fibrillation compromises your atrial.
Right.
Now, how far reverse? So that atrial is not if it's a valvular and a non-valvular. How much it reverses that atrial complex?
So atrial pump reverses. So once you give cardioversion and all, they go into stunning. Immediately it doesn't revert back to the atrial kick, but eventually it returns.
Does it recur to the full extent? So ultimately, it is very important.
So it's a progressive disease, and whenever there's a sinus rhythm, we get back the atrial kick. But as the disease, because this is a continuous process, we might not be eventually able to get into sinus rhythm, and we might not be able to get into the atrial kick also. So that will go away with time. But if they come into the sinus rhythm, they will have the atrial kick return back.
We are talking about paroxysmal atrial fibrillation. Does that again compromise the atrial kick every now and then, causing a persistent?
Yes, so it's a progressive disease. So every time
reverse then again the atrial kick with your correction also.
Right. So see, whenever they will come into sinus rhythm, they will have the atrial kick which will come back. But as the disease progresses, and if you are not able to get them into this thing, and the atrias are getting dilated, anyways the atrial kicks are getting weaker.
So how much you achieve with your correction also?
No, we should try to attempt. See, whatever possible. It's a natural. It's a progressive disease. But we should try as much as possible to get them back to the sinus rhythm whenever it is possible. If the LA is significantly dilated and all those things, whatever you try, they go into persistent and permanent atrial fibrillation.
So that means there is a persistent clot accumulation can always be there.
It has to be there, even if they are paroxysmal AF and if their chest stress score is high. Intermittently, even if they are in sinus rhythm, they should be on anticoagulation if their chest stress score is high. The permanency of AFib doesn't decide whether they should be on AFib or not. Even if it is paroxysmal, if it occurs once in a while, and if their chest stress score is high, they should be on anticoagulation.
You said we reduce medication. We have been coming to only for cardioversion.
Right.
But does it give a guarantee of a year, complete year?
No, nothing.
Because then anytime we can get.
I know, this is one of patient I gave you a very anecdotal example, but I think Dr. Mazhavadi can add something.
Actually, you just need 5 minutes of air to start the thrombogenic process. Again, data number one. Number two is for this particular patient, although he insisted on getting cardioversion, if he's a well-read guy, then he knows the downside of it. Most patients who have symptomatic AF also have runs of asymptomatic AF going on in the same very patient. So unless you exclude asymptomatic AF, you can't say he's fully safe. And
so atrial kick about it.
Yeah, atrial kick, as Rahul correctly said, it takes a little while for it, and we normally wait for about 6 weeks for the atrial kick to return. And if the scar, as Rahul already pointed out, with AF is an irreversible disease, you can just manage it. Once a patient goes into AF, he's branded forever for AF. He always switches from paroxysmal to permanent or paroxysmal to persistent and back to paroxysmal with time. But eventually they all land up in permanent, and they have the consequences of permanent AF. So one of the main things what happens to the atrium with longevity in AF is that they start increasing the fiber content in the atrium. And when the fiber content increases, the electrical circuits in the atrium become very disorganized. And they eventually form nodes within the atrium. And instead of having a linear flow or a wavefront flow, they start having rotors. So at this stage, sending a patient to us for air ablation is not very effective. So you want, the earlier the patient comes to us, the better it is for him in terms of keeping him free of air in the long term. So most of us see patients, normally almost all my patients are persistent AF. So when I ablate, I have to do a lot more lines than just isolating the veins. So I tell them when they come to us, let's say, on an average, patients come to me after 4 years of detection of AF, which means the patient has started AF pathophysiology at least another 4 years or 5 years back. So that's 8, 9 years, way too late in the national history of AF fibrillation. So the sooner you detect, the sooner you correspond with your cardiologist, and the sooner you start the conversation with the patient and the relatives, the better their long-term AF-free survival is.
I think paroxysmal AF is the time when this is the best time to have them.
Yeah, absolutely. The results are quite good, and with the new capsules which are available, what we use, the results are almost at 80%. But when they come to us with persistent, or when the chamber sizes are on the left atrial side, but in AF, when you do echoes, you want to look at the left atrial side. That number is critical. Because if the left atrial side starts going into the late 30s and into the 40s, then the results start coming down, which means the disease has been so long with the patient that the atrium itself started negatively remodeling. So all these factors come into play when you look at the results, when you counsel your patients for AF ablation.
So I think the message is earlier referral for AFib ablation, especially in paroxysmal AFib, will do wonders. Then I think at least that's the best substrate to have these patients for the ablation.
Good afternoon. So let's say I have a patient who underwent 7 days halter for some other reason, and in this halter there is an episode of AF, but very shortly, like 4 to 5 weeks. So should I anticoagulate? I just want to know the concept of AF burden in this patient.
Right. So as Rahul pointed out, AF burden per se is not an indication for anticoagulation. And the duration of AF is just 5 minutes for him to develop prothrombosis. So looking at this, once you see the AF, you have to label him as AF. Now, for the long-term treatment of AF, you want to look at patient's symptoms. Now, is all AF safe? All of us have AF, for example. Now, do we all qualify for AF ablation? The answer is no. Because AF ablation is given to patients who are symptomatic. And what do I mean by symptom? Not occasional blip or palpitations, like palpitation. The palpitations have to be, or the symptoms have to be in such a manner that it is more than nuisance value. So that is it's a subjective indicator of what is the nuisance value for me is probably not for you. But that is the benchmark for qualification for a patient coming to AF. I mean, I can talk about AF ablation in separate things, so it's a vast topic. But this is where the ballpark issues are, and I think Rahul covered them quite well. He covered all the aspects, and the patient journey is quite interesting. I think that's the best way to cover it.
Yeah, we have covered this is the journey which all of us are going to face, and we are going to see the patients at different stages.
Yes.
So patient might come with stage A pre-AF to all of us. With risk factors, modification is important. Might end up with further stages as we said, pre-AF, and then various stages of AF as we discussed based on the AHA. So we are going to see the patient maybe in different stages, but we must be aware, and we should begin with the primary prevention of all the risk.
And just one last thing about the symptoms of AF, palpitation is not the only symptom. They have fatigue, inexplicable fatigue, vague symptoms, mild dizziness, tiredness, unable to concentrate, memory lapses. These are the whole spectrum, and very subtle symptoms they're all valid as symptomatic AF. That's what I'm coming out.
Yes, sir.
Those who are getting occasional palpitation, there are some watches or mobiles available only, whether it's useful.
So Apple Watch, yeah, it is very useful because I recommend, previously I used to give these event recorders to my patients. And we were able to diagnose a lot of things. Patients get AF for 5 minutes, by the time they go to the hospital it's normal. So these watches are extremely important. A lot of AF detection algorithms are there in these watches, and patients are now coming. I think Brajesh also pointed out that with these available of these gadgets, we are able to diagnose these much more often, and we can take preemptive actions to prevent any catastrophic event in these patients. So they are useful.
I agree.
I have some answers.
Yes, sir.
Please. The course, sometimes they mention enlarged left atrium already. Again, we are not able to clinically decide. It is on the clinical setting. How far do I go ahead on that? Just an enlarged LA.
Enlarged LA may be a reflection of diastolic dysfunction in these patients, which may be because of hypertension, sleep apnea.
Find everything. That's what I'm just trying to know. LA is there, what do I take any measures or preventive measures on that?
So you have to control the risk factor, because if just the LA is dilated, That means they are having LDH, which may be related to hypertension, sleep apnea. So primary prevention, diabetic patients, all those things which are causing diastolic dysfunction. So I think these are the patients where we need to aggressively control the risk factors. As we have stage B, A, B, C, D of heart failure, we have stage A, B, C, D as we discussed about the atrial fibrillation. So we have to do a primary prevention, lifestyle modification, smoking cessation, all those things, whatever we discussed, which is the common root hypothesis for everything.
I think a lot of time is there. I think we should ablate AF now and proceed for the next topic.
Thank you very much. Especially please distribute in each row and they can break a little bit and have this. I think this row and this row, everybody was answering well. Thank you. Thank you very much.
Thank you, sir. I would request panelists and the chairperson to felicitate our speaker. Thank you all. I would now invite Dr. Saurabh Deshpande, our speaker, chairperson and panelists, Dr. Rishi Bhargav, Dr. Son Kamre, Dr. Rishikesh Thakur, Dr. Sandeep, Dr. Nitin Jagasia, Dr. Nachiket, Dr. Nikhil. Thank you.
First three speakers were from Apollo with no need of introduction. So I will take the opportunity to introduce Dr. Saurabh Deshpande. He was my student at LTMMC Science Mumbai during his medicine residency. He did his DM cardiology from Trivandrum Medical College and postdoctoral fellowship in cardiac electrophysiology from Sri Jaydeva Institute of Cardiovascular Research, Bangalore. He is working as a consultant cardiac electrophysiologist at various hospitals across Mumbai and Navi Mumbai, including Apollo Hospital, Belapur. He has done presentations at various national and international forums, many publications to his credit, in journals like JAMA and AJC. He is a proctor for various devices. Over to Dr. Saurabh Deshpande.
Thank you so much for those kind words, sir. Good morning, everyone. After that session of atrial fibrillation, which everybody loves, I think we'll go on to some narrow-complex tachycardias. Disclaimer, atrial fibrillation and flutter are not covered in this particular talk. So whatever we discussed till now was different and this will be different. So I'll be trying to cover what exactly is narrow-complex tachycardia, how to classify it. The most common and most practical way that we all can use is something called a short and long RP. To how to do that, we'll discuss it. We'll discuss the mechanism. It may not be very relevant in clinical outcome of the patient, but then it becomes important if you can actually diagnose or find out if there is some particular mechanism in the tachycardia. And the most important thing is effect of adenosine and how to give it. So that we'll go through, and then individual tachycardias we'll go through. So conventionally, when we talk about narrow complex tachycardia, it is any rhythm with heart rate of more than 100 beats per minute with QRS duration which has to be less than 120. Now again, mostly the flutter fibrillation conventionally is not considered, and the narrow complex ventricular tachycardias are not considered to be in the conventional way for narrow complex tachycardia. So the left posterior fascicular VT, left anterior fascicular VTs will not be discussed today. So whenever you have an ECG, How to diagnose it? Go methodically. As I have pointed out here, ECG recording, the standardization, I think the first talk, all of you were there. Dr. Mahesh has taken this very well, that you have to look for standardization, look for the speed, and then go whether find out it is regular, irregular, then find out whether it is sinus or not, or where the P wave is standing in respect to the QRS, and then go for the presence of absence of AV dissociation. This is a very busy chart, but I think all of you might be aware of this particular thing, that whenever you have a narrow complex tachycardia, first of all, look for if it is something called as left posterior of anterior fascicular VT. It's not very difficult to diagnose. I think in the next talk, Dr. Mantavadi sir will be alluding to all the wide complex tachycardia. He'll cover that. If you have ruled that out, find out whether it is a regular tachycardia or irregular tachycardia. If it is a regular tachycardia, look if you can see the P waves. Now, if you can see the P waves, then you can find out the relation of P wave with the QRS. So, if the P wave is negative in lead 1, then it is likely to be an atrial tachycardia. If it is positive in lead 1, it is likely to be sinus tachycardia. Again, this is when you are suspecting some AV node non-dependent tachycardia. I'll be coming to that later as well. If there is no discernible P wave at all, then 80 or 90% of the times what you are dealing with is an AV nodal re-entry tachycardia. There can be some cases where it can be junctional tachycardia. It's not very common. Again, when you have a P which is after QRS, then you can go for the classification of short and long RP. I'll be alluding to that later on in my talk. And if your tachycardia is irregular, it can be anything of AF, flutter with variable block, or AT with variable block, which I'll not be covering in this. Now, what do you mean by short or long RP? So, if you see the figure on the right hand side, so this is how we find out whether it is a short or long RP tachycardia. Just look for the RR interval and look where the P is falling. So, if the P is falling less than half of that RR interval, it is considered as short RP tachycardia. If it is more than half of that RR interval, it is called as a long RP tachycardia. It looks very simple if you have ECGs like this, where you have very clear short RP and very clear long RP tachycardia. But when you have ECGs like this, it becomes very difficult to find out where the P is exactly. You actually cannot see. There is no P. There is some QRS, some other deflection going on in the ECG. That time you have to look for the clues. So what are the clues? So the easiest one, what we can find out is find out the morphology of that particular thing which we are calling as a T wave. So if it is a T wave, the T waves are more rounded and less peaked. All of you have seen PQRST in your regular ECGs. So if it is not rounded, if it is a peaked deflection or a peaked wave, then it is likely that a P is falling onto that T, and that is actually a long RP tachycardia what you are dealing with. Or the second thing is which is called as a Bick's rule. So again, if you find out there is a P wave falling here on the T wave, then the rule says that the second P wave will be hidden inside the QRS. So these are some of the clues which you can use to find out in such tachycardias whether it is a long or a short RP tachycardia. So anybody who can guess this? What is the most common short RP tachycardia? Okay, it's AV nodal re-entry tachycardia. And what is the most common long RP tachycardia? Anybody for this? All of you see it every day. It's sinus tachycardia. Yeah, it is difficult to digest that, but yes, the most common long RP tachycardia is sinus tachycardia, which does not require any treatment. Now, coming to the mechanism, don't go into the intricacies of all these triggered activity and automaticity and everything. Just you have to remember that there are 3 different types of mechanism which are there in a narrow complex tachycardia. These are useful to us for medical therapy as well as the EPRFA that we do for all these narrow complex tachycardia. So, conventionally, if you see, the regular reentrant tachycardias are the most common. And those are the AVRTs, AVNRTs. Sometimes atrial tachycardia can have something called a micro reentry, or in a diseased heart, it can have a macro reentry as well. Micro means a smaller circuit, macro means a larger circuit. There can be automaticity or automatic tachycardia, which are more common with the EATs, that is ectopic atrial tachycardias. MAT and JET are not very common and they generally require only medical management. JET are more commonly seen. JET is junctional ectopic tachycardia. They are more commonly seen in children, but sometimes you encounter them in adults as well. And you have something called as triggered arrhythmias, which are common, which can be there in the atrial tachycardia. So I just want a volunteer just to find out how is adenosine given. So you all give adenosine, right? So how is the adenosine given? Anybody who can volunteer? Anybody? Now this is, you're giving every day, right? Every emergency you might have a patient or, yeah, please, sir. Sorry? So, can you give him the mic, please?
Sir, the ampoule is broken and immediately you give stat and followed by some 5% dextrose so that it should not be mixed.
Okay, which vein do you give it, sir?
Left cubit.
Okay, you have chosen the cubital vein. So you have put an IV line inside, right? You have put an angiocath and you are now planning to give adenosine. So do you look for something in that angiocath or do you directly give adenosine?
No, first heparin is pushed.
Heparin is pushed. Heparin for what, sir?
If it is blocked. If it is not blocked, then give the adenosine.
No, you have just put, the patient has come to you. You have just put an IV line.
Give the adenosine and then followed by 5% dextrose.
Okay. So, thank you so much, sir. So, the most common complaint that we hear in narrow complex tachycardia or the common problem what we encounter is, हमने adenosine दिया और कुछ भी नहीं हुआ narrow complex tachycardia को. That I think you might have heard a lot of times. But that the adenosine actually is not a problem. The method of giving adenosine is the problem. So when you have put an angiocath or you have put in scalp vein, whatever is available to you, always ensure that there is no blood inside that angiocath or the line which you have put. What happens is when the adenosine which you are giving from outside comes in contact with those RBCs or the blood, it gets disintegrated there and then itself. See, adenosine has a half-life of 6 to 10 seconds. So if it comes in contact with the blood, it immediately goes off. It does not reach the heart. So your aim of giving adenosine is gone. So always, whenever you have put an IV line, you are planning to give adenosine, flush that line and ensure that there is no blood in that line. Once you ensure that there is no blood, then push adenosine and whatever sir has already rightly pointed out, immediately give another flush. So adenosine does not fail 90% of the time. The method of giving adenosine fails. So always remember that. And if you have given adenosine properly, this is what will happen. So in an AVNRT, it will terminate. So what will happen in AVRT? Again, it will terminate because both these tachycardias might have something to do with the AV node. So AV nodal tachycardias will terminate. Now there is something called as atrial tachycardia, junctional, the sinus rhythm and the flutter, where they have nothing to do with the AV node per se. Everything is going on in the upper chamber. So what will happen with adenosine? Yes, some atrial tachycardias can terminate. So there are atrial tachycardias which are adenosine sensitive. Those can get terminated, but the more common thing what will happen is AV block will happen and you will see those P waves marching through. And same thing will happen if it is a sinus rhythm or the flutter. Now JT has a variable response, sometimes it terminates or it has no response. So this is what you will get if you give adenosine properly. So that is what is most important. Ensure that the adenosine is given properly. Again, second most important thing which I hear, now I have given 6 milligram, the second dose is another 6 milligram. So if you have given adenosine properly, 6 milligram and second 6 milligram does not make it 12 milligram. Always remember that. It becomes a second 6 milligram. So if you want to give a higher dose, give 12 milligram the second time. It is not 6 plus 6, 12. It is 6, 12, 18. So you can go up to 18 and you can stop there. Then you need not give adenosine at all. What is one thing you tell the patient when you give adenosine? You are planning to give adenosine to the patient. What is one thing you tell the patient? Syncopal, okay? Flushing, okay? Breathing, somebody said. So there is actually a catching sensation in the chest which happens when we give adenosine. Always tell the patient that, otherwise they become very anxious, because the moment it causes AV block, so it also acts on the pulmonary, the alveoli, and it causes something called as a catching sensation in the chest. So always tell them that this will happen and it will go off, because adenosine effect will last for the 6 seconds or 7 seconds, whatever. I'm sorry I've taken a lot of time on adenosine, but this is very important because it is day-to-day life we are facing those problems. There is something called as SVT with AV dissociation. It's not a very common thing, but then we once in a while encounter it. Can be there in the AVNRT situation, the JT situation. The flutter fibrillation can have that, you all are aware. Only the AVRT is ruled out. That cannot have an AV dissociation. Now coming to the first part of the narrow complex tachycardia, that is short RP. This is most commonly seen. Many of you must have seen one tachycardia like this. But then sometimes what happens, such patients present with rhythms like this, which I think will be covered by Mantradi sir in the next talk. But here, if you see, there are some clues that it is actually not coming from the ventricle. It is coming from above, and then there is some problem in the in between the conduction system and coming down, which is called as supraventricular tachycardia with aberrancy. So AVNRTs can present with rhythms like this, and they actually can be ablated at the same place. Just I think Charan will remember one of the cases which we have done recently. So mechanism, again we discussed this. There is re-entry. So this is a very old concept. This has no anatomical basis whatsoever, but we use it everywhere and anywhere to show people this, because this is how you can explain AVNRT. Now you have an AV node, it has a slow pathway, it has a fast pathway, there is some block, unidirectional block, so the beat will not go here, then it will go from here, come up, something. So you have a short long or long short, so you have multiple types of AVNRTs. The commonest is short long. So that is what will happen in a normal beat when the beat is going from the fast pathway. If it goes from the slow pathway, it can go up or go down. It forms a circuit and then gives you an AVNRT. That is how you explain to the patient as well. How to treat it? Everybody, all of you are aware about Valsalva maneuver, the carotid massage. The one point about carotid massage, never give carotid massage on both the sides simultaneously, and always auscultate the carotids before giving carotid massage. Especially in the elderly, it can lead to stroke. So avoid it if there is brewing, avoid it if it is elderly, don't give it. Beta blocker and CCBs are sometimes required if adenosine does not work. Medications, yes, the commonly used are beta blockers, CCBs. What we have found out is sometimes potency of the CCBs is higher than beta blocker, but it varies from patient to patient. And as early as possible, refer the patient to us for EPRFA, because these are treatable arrhythmias. The success rate is to the tune of 98-99%. 1% cases can recur, but then it has a very high success rate, and all throughout their lives, they will not require any medication. The second type of short RP tachycardia is the AV re-entry tachycardia. So atrioventricular re-entry tachycardia. Again, it looks almost similar to the AV nodal re-entry tachycardia. If you look at the ECG closely, the lead 2 is showing the RP interval to the tune of around 100 milliseconds. So it covers 2 small squares. That is one small clue which can differentiate AV NRT from AV RT. AV NRT generally either you cannot see the P wave at all, or the P wave will be within 70 milliseconds of the R wave. That is a small clue, but it is not very easy to diagnose every time. Now there is why I have written this orthodromic word. What do you mean by orthodromic is in a tachycardia where the antegrade limb. So what do you mean by antegrade limb is something which is coming from up to the down, from the atria to the ventricle. The way it is coming down is via AV node, and the way it is going up is via the accessory pathway. That is how the circuit is formed in an orthodromic AVRT. The AVRT can be a broad complex tachycardia if it is an antidromic AVRT. So what do you mean by antidromic is the conduction is happening from atria to ventricle via the pathway, and then from the ventricle to atria via the AV node. So that is why the antegrade limb is broad. Sorry. So it looks like this. Or sometimes we encounter some ominous rhythms like this. What is this? I've already given the diagnosis. Anyways, it is AFWPW. So what is happening here? There is some irregular rhythm going on in the upper chamber, and then via the pathway, the rhythm, the atrial tachycardia or atrial fibrillation in this case is traveling down, and it is causing some picture which is suggestive of ventricular fibrillation. It is an ominous thing. Patient can collapse, so immediately has to be cardioverted, specifically with DC cardioversion. This second point is very important. If you see a rhythm like this, never give these medications. Why? What will happen if you give anything like this? Exactly. So you will be blocking whatever safety mechanism is there in the patient. Whatever is keeping the patient alive, you are actually blocking that. So if you give anything of this, it is a death sentence for the patient. Please avoid it. The drug of choice is procainamide IV, which is not available in India. So the treatment of choice in India is a DC cardioversion. I'll not go through the asymptomatic WPW because that is a separate topic. Today it will be covered in the evening. But if the patient has symptoms, specifically, then better to go for EPRFA as the first line of management. And if the patient is not willing, then medications will be the second line of management. Asymptomatic has different management. We'll see it in the evening. Coming to the long RP tachycardia, as I discussed, there are two types. It is AV node dependent tachycardia and AV node not dependent tachycardia. So AV node dependent are AV NRT. There are some rare forms of AVRT which has a slowly conducting accessory pathway, which are called as permanent junctional reciprocating tachycardia, which can be there in case then it can present as a long RP tachycardia. There are AV node independent tachycardia, which can be a sinus tachycardia or then atrial tachycardia. Whenever you have those, this is a very elegant paper which was published in 2014. It's a relatively old paper, but it has given us some clues that how to find out if so in any case of long RP tachycardia, the most common thing has to be ruled out whether it is an atrial tachycardia, because it is an easier diagnosis out of the three. So these are the 3 points which can give us a clue whether we are dealing with atrial tachycardia in a patient who is presenting with a long RP tachycardia. So if the RP to PR ratio is more than 1.6, that is a long RP again. Absence of P waves in the inferior leads, or the P wave duration is more than 96. So what they found out is this 2 out of 3 has 100% positive predictive value to find out it is an atrial tachycardia that we are dealing with in a case of long RP tachycardia. Now, so when we are talking about atrial tachycardia, definition is just academic. It has atrial rhythm which is going on more than 100 and anywhere above the AV node. The mechanism we have discussed before, it can be focal, macro re-entry. So I'll not go into these details. It's difficult to find out, but sometimes it is useful for us during when we are planning ablation or during the procedure. These are some of the academically important tachycardias that we sometimes hear as a differential from many people. Frankly, I would love to have Sir's opinion on this. It's very difficult to diagnose this. Even when you get it in the EP lab, you cannot term a patient as a sinus node reentrant tachycardia or an inappropriate sinus tachycardia, even in a cath lab. So these are some of the academically useful diagnosis, differentials you might say. So you can just leave them on medical management or anything and some behavioral changes, that's it. Important clue to find out whether you're dealing with this or you're dealing with a pathological tachycardia is sudden rate of change of heart rate. So whatever tachycardia has something to do with the sinus node, the heart rate goes up very gradually. So it will be 90, 100, 110, 120, 140, whatever. But when it is a pathological tachycardia like an AVRT, AVNRT, atrial tachycardia, it goes from 70 to 160 within seconds. You will not see the heart rates in between, which is one of the clues where you can actually find out whether you're dealing with a pathological atrial tachycardia or AVRT, AVNRT, and not any of these fancy diagnoses. Management is almost similar. There is not much of a difference. I have included ivabradine because there are some adenosine-sensitive atrial tachycardias which are responsive to ivabradine. So that is one thing we can try if patient is not feeling for EPRFA. So I have written 3D more than 2D. It's all personal choice. But then what I think is, in a patient who has atrial tachycardia, it is very easy to map that, and then if by chance you get some lesion and you get maybe some paroxysms of tachycardia or some few beats, it is easier to map in a 3D than a 2D. The second long RP tachycardia is atypical AVNRT. You might not see in regular practice. I'll not go and dwell into too much detail. The only difference between regular AVNRT and this particular AVNRT is the path that it has taken to go from upper chamber to lower chamber is the fast path. And the path which is taken from lower chamber to upper chamber is the slow path. Mind you, in a case of AVNRT, neither the atria nor the ventricle is a part of the re-entry circuit. It does not require it. If a patient has AVNRT, even if you cut off the atria, even if you cut off the ventricle, patient will have AVNRT. But this is the way that we conventionally do it. Then if you have, so the hypothesis and all these are too high-fi, it's not required routinely. Management, if you see all my slides, it is almost the same. You have same medications available, you have same EPRFA, and management, the EPRFA technique will change as per the tachycardia. This is not very common, but if you have a narrow complex tachycardia and the patient presents to you with LV dysfunction, this is one of the diagnoses that should be suspected in that particular patient, especially in a young patient, though there are cases where we have seen these patients at 60s as well. So these tachycardias actually go incessantly. Once they start, they don't stop. So these actually present like an incessant narrow complex tachycardia, generally longer RP, and they have an accessory pathway which is a part of the circuit. And that accessory is the only thing which has a detrimental property otherwise. But in this case, the accessory pathway itself has detrimental property. So that is how it is the mechanism is again the same as AVR. Common its location is posteroceptal, and it can, so that this is the diagnostic feature that there are some tachycardiomyopathy associated with these particular tachycardias. The treatment of choice, you might have guessed, it is obviously the ablation. We can manage the heart failure in between till the time you are treating the patient for ablation. I'll not dwell on to again. I'll just finish off a few case examples. This was a 40-year-old male with recurrent palpitations. It was very difficult to get this particular ECG. Patient had symptoms for 7-8 years almost, but the patient never could get an ECG. The last time when he had symptoms, thankfully he had some ECG nearby, and this was taken. And this, if you can see, there are P waves very clearly seen, so you don't have to judge. It's a long RP tachycardia. And this was found to be somewhere around the inferior tricuspid annulus. This was done under 3D. And this is where we ablated. I know the number of lesions are more. It was like a micro re-entry kind of a thing. Then similarly, this was a younger female. Now, when this patient was referred to me for the first time, again, the P waves are not seen. If you see the ECG, the P waves are not seen anywhere. So it was sent as a patient, a case of AV nodal re-entry tachycardia. But when we started the EP study, there was proper AV dissociation. So there are clues that it actually we are not dealing with the atrial tachycardia. It was we are not dealing with AVNRT. It actually was a parahesian atrial tachycardia. And so if you see here, I don't know how many of you have seen an EP study before. This is one of the catheters which has 10 poles. It is called a decapolar. This is one of the catheters which has 4 poles. It is called quadripolar. And this catheter, if you see, it has a very long dark pole and followed by 3 more poles. So this is the ablation catheter. So this particular tachycardia was actually ablated retrogradely. This has gone from aorta to the non-coronary cusp, and it was ablated just near his area in this particular location, and we could get rid of it. The last case that I'll be discussing is what is not very common, is called as PJRT. Again, this patient was an elderly, which is surprising, presented with heart failure and had a long RP tachycardia. This is something called as pseudo VAAV response, which we saw in that particular patient, so surprising for us, it was not on the right side. So this, if you see these are the two atria that we have mapped. This is the right atrium, this is the left atrium. It was somewhere what we call as aortomitral commissure. So the aorta goes from here out. This is not a very common location for decremental accessory pathway, but this is where we found out, and it could be ablated there from the left side. Thankfully, the patient recovered to normal ejection fraction within next 3 months. So to summarize, narrow complex tachycardias are very common. All of you have seen in daily day-to-day lives. The tachycardia management has to be proper, and you can actually do justice to the patient if you ablate those tachycardia. You can use a 2D or 3D as per the operator discretion. Thank you. Thank you.
See, I remember one incident when I was an intern. In mid-80s, I was an intern at Safdarjung Hospital. You had written Delhi, so I'll ask you later on where in Delhi you did your DNB. I did from Gangaram, so.
Delhi, okay. No, that was DNB. Yeah.
DNB,
yeah.
okay.
DNB is there only.
I was an intern in the casualty, and that time it's a high volume hospital. So there was a postgraduate in medicine, Dr. Radhakrishnan. I think he still must be there in Escorts as a pediatric cardiologist. He was doing MD medicine. So we were standing by. SVT was SVT that time. There was no AV, RT or NRT. We didn't have any knowledge. So the tachycardia comes, and isoptin used to be given at that time.
Isoptin?
Yeah, as I remember.
Isoptin was given for tachycardia?
For SVTs.
Okay.
Dilzem you started giving later on. And then now adenosine.
Yeah,
I'm talking of mid-80s.
Right.
So isoptin was given, patient went into cardiac arrest. So this Dr. Radhakrishnan immediately said, this is WPW, and they started reviving the patient. We got very fascinated. How this postgraduate student knows that this is WPW. He gave isoptin, patient went into arrest. This is, I remember, 35 years back. So we were very fascinated, very knowledgeable doctor. Just one injection and he knows what is the diagnosis, because patient was in SVT. There was no clue for a WPW. So here I want to ask you, because when the SVTs are seen by physicians, actually, there is no cardiologist in the emergency, and where not to give adenosine or where to suspect, that is more important for a physician to know, where to suspect something sinister and not to, now adenosine is a reflex, they will just give it. But are there situations where one should suspect that, you don't want to at that time block the AV node and give something else?
So sir, frankly saying, I'm very happy that you said that it is a reflex to give adenosine. My observations are very different. People are still not giving adenosine. They are fearful of adenosine. I don't know why, but I'm happy that you said that. Adenosine can be given in any tachycardia other than the one which I showed you, AFWPW. Even if you give adenosine a ventricular tachycardia, nothing will happen. Because it's already, AV is dissociated. We used to do that. In a wide complex tachycardia, we still do it. We always try to rule out if we are actually dealing with SVT or VT. It's a difficult scenario, sir. We'll discuss in the next talk how to differentiate SVT and VT. But it is difficult. So in a wide complex tachycardia, giving adenosine, there is no contraindication. The only contraindication is this AFWPW. Should not be given. You try to give it in every tachycardia, doesn't matter.
And one thing more, I was going through a podcast where they were of SVT. The cardiologist was saying, he gave a very practical tip that you keep on talking to the patient when you are giving this, because of that bronchospasm and chest constriction you get for some few seconds. He said if you keep talking to the patient while giving, he is very relaxed, and that few second things doesn't matter much to him. So he said you keep talking to the patient while you are giving adenosine. I just heard that. So thank you very much for your nice presentation.
Thank you, sir. I would request the chairperson and panelists to felicitate our speaker, please. Thank you, Saurabh, sir. Next, I would invite Dr. Rajkumar Mantravadi as a speaker. Chairperson, Dr. V.K. Verma and Dr. Charan Reddy. Panelists, Dr. Auti, Dr. Manish, Dr. Asmita Deshmukh.
So whilst the talk is being uploaded, I just have a quick note on the adenosine fear. Actually, there's no need to fear if a patient goes into VF because of accessory pathway conduction during tachycardia and the crisis situation. All you have to do is DC cardiovert the patient, that's all. And you can shock the patient as many times as you can. There's no fear of causing stunning in the ventricle, EF going down. All these are just myths. I have had patients where I've shocked about 100 times or more than 100 times one night. The patient went normal EF, there's no issue in England. So don't feel shy to shock. It's a good thing. Not for, well, I'm not saying in a perverse way, but for the patient it's very good. It's a very safe treatment. You can give it in pregnant women. And there should be a low threshold for cardioversion as long as you take the precautions for cardioembolic stroke and things like that. Okay. So I'm not going to bore you with too many ECGs on this, but I'm just going to touch upon the general principles. And broad complex tachycardia is a hairy thing for not only physicians, cardiologists, it's also a hairy thing for the electrophysiologists at different levels and for the reasons which I'm going to talk to you about. So this is a 44-year-old man. This is better. So this is a 44-year-old man with multiple episodes of palpitation and normal echo. The most striking feature in this particular ECG, which is otherwise unremarkable, is a short PR interval. And when they took his ECG during tachycardia, there was this broad complex tachycardia. I mean, now we've discussed broad complex ad nauseam previously, so I don't want to go into the definitions of it. Anything which is more than QRS, which is broad complex. Now, the same patient had this as well. And in the same patient, same time, the tachycardia changed from one broad complex to a second broad complex tachycardia. So, it is possible for one patient to have more than one broad complex tachycardia. I mean, there's a reason why I'm putting all this together. I'll just tell you, and it'll be easier. You can have antidromic tachycardia, which the previous speaker elaborated in detail, or it could be orthodromic tachycardia with a bundle branch block, right or left, depending on what the patient really has. And you can have multiple broad complex tachycardia with the same accessory pathway. So by definition, it does not, if you have a broad complex tachycardia, you don't want to go in with a fixed mind. You don't want to have mental models to try and solve the issue right then and there. All you want to have is a patient safety at that point. So again, I'm really thankful because he went into the details of adenosine. Adenosine is a very useful thing as long as you give it correctly. And it either has no effect at all, which tells you a story. And if the patient feels that discomfort, which means the adenosine has reached the heart, you can take it home. You can take it to the bank. If the patient says, I felt uneasy and there's no change, which means the adenosine has reached the heart. Okay, so if adenosine has no effect, then it's probably a VT, atrial tachycardia, or atrial fibrillation with accessory pathway conduction. Or the adenosine may just terminate the tachycardia. So if there's a broad complex tachycardia and the patient is not in hypotension, then you can play around with adenosine. If there's hypotension, just shock the patient and just move on. Don't worry about pinpoint diagnosis of broad complex tachycardia when you are seeing the patient in the ER. That's not the time to do it. You record the ECG. It's very important to record the ECG. Later on, you can do the analysis. But if you have the luxury of time and the patient is stable, then you can do this adenosine game. So if the tachycardia terminates with a bolus of adenosine, then it's SVT with aberrancy. What is aberrancy? Aberrancy is either it's coming through axillary pathway or there's a conduction abnormality below the AV node or the lower part of the AV node. So that's your aberrancy. So it could be atrial tachycardia, SNRT, which is almost an academic relic, really. If AV block reveals, so if you give adenosine and it slows the AV node down, so your ventricular rate will go down, but you'll see dramatic P waves coming on, or you don't see P waves at all. So that tells you what the atrial electrical activity is. So it gives you a window, of opportunity to look at the atrial side of electrical activity. So it could be flutter, it could be AF, it could be atrial tachycardia. But again, as I said, if you see a patient with broad complex AV, please do not venture into these diagnoses. It's not really relevant at the time of treating the patient. Retrospectively, you can have ad nauseum discussions and we can go into the algorithms and things like that. Okay, so here is an antidromic tachycardia which comes down the axillary pathway and goes up the node. And in children, you can have an axillary pathway which comes down an axillary pathway and goes up a second axillary pathway. So these are what I'm trying to show you is what are the possibilities, what is the differential diagnosis in a broad complex tachycardia. So if you see this, there's an AV node, you have an atrium, this is a schematic diagram for all axillary pathways. So you can have, this is your bundle of his, right bundle and left bundle, and that's a traditional axillary pathway. It could be anywhere, left free wall, anterolateral wall, right free wall, post-receptal, anteroceptal, anterior. There's a huge bunch of them. I think the subsequent speakers will talk about it. But it is an accessory pathway. It has an atrial connection, it has a ventricular connection, and it's not really related to the conduction pathway directly. However, you have accessory pathways which are connected to the conduction system directly, which are atriofascicular pathways, and you have AV node sticking its attachment to the ventricle, the nodoventricular pathway, and you can have a direct right bundle or occasionally left bundle fascicular ventricular pathways. So what am I trying to say? I'm saying broad complex tachycardia has a huge spectrum of possibilities, and don't rack your brain over it. Okay, what I did not say is the more bigger version of the differential diagnosis, that's the VT. Okay, so in electrophysiology, you can have tachycardias coming from any part of the heart. They do not stick to coronaries or they do not stick to any conduction system. They can come from any part of the anatomy. So, and the anatomy is not a uniform structure. You have trabeculae, you have thick structures, you have thin structures, you have crista terminalis, and these are the areas where your atrial tachycardias can come. I'm not going into it because it's deep science there, but all you want to know is if you study the P waves and the morphology carefully, it'll give you the clue to the location of where it's coming from. Okay, there are protocols on the Chrysler, Greston field, and so on and so forth. It's not useful to know. And ventricular tachycardia can come from any part of the ventricle, and both right and left ventricle. It could come from mid-myocardium, it can come from the epicardium or the endocardium. And if the heart is totally structurally normal, it can still come from neural crest depositions of embryological remnants. And they can come from RVOT, it could come from aortomitral continuity, it can come from mitral annulus, anterior mitral annulus, posterior mitral annulus, it can come from crux of the heart. So, as I said, any part of the heart you think of, imagine of, a VT is possible. A broad complex tachycardia is possible. Okay, and there are protocols to it, depending on whether there's structural heart disease or no. And if you look at one thing I wanted to bring to your notice is, if you compare these two, this is your left bundle, and this is your right bundle. Right bundle is just 1 millimeter wide, which is why statistically you have right bundle branch block, which is deemed as normal. Left bundle is a huge thing. It's got numerous arborizing. I'll show you a picture of the left bundle as not artistically imagined, but the real picture. So if you have a left bundle involvement, then it denotes seriousness. So in short, you look at ECG evidence for broad complex tachycardia, look at tachycardia characteristics, which we normally do in the EP lab, and generally patients land up with 3D mapping, because 2D mapping, it gives you a lot of information, but it's like a lot of smoke. You don't really get to the precise, accurate diagnosis and treatment. And you want a patient to go home safely, and you don't want recurrences. So, and you want to reliably diagnose the problem. So all these three are fulfilled using a combination of 2D and 3D, but 3D is almost taken over 2D for the following reason. So in an EP lab, you stick catheters through the groin to the heart. There are multiple catheters, as my previous speaker has shown. I'm not going to go into it, but I'd like you to look at the amplifier and the junction box, where the signals are amplified and they're converted into computer understandable language. It's called digitization, and they're rendered. So it shows, it gives you pretty pictures, basically to easily understand what is it, a snake or is it a tree, you know, that kind of thing. And so how do we see the electricity in the heart? So we place catheters and we record electrical signals. Earlier it used to be painstakingly taken from every point. It's called point-by-point mapping. Or we use complex catheters which have, in one go, you get all the information. So these are multi-electrode arrays. I mean, there are different versions of, it comes in different sizes and shapes. They increase the size, as I just mentioned. You get digitize it, and you render it to give you pretty pictures. So the main thing is, the more signals you collect, the more accurate it is. It is not true that 2D is sufficient. 2D is like, in my view, it's an auto rickshaw. You can come from Pune to Bombay, but it's, you know, it's not the best way to come. You have better ways of coming to Bombay, maybe by train or by flight, and why would you come in an auto rickshaw? But it is a valid mode of transport, you know, there's no doubt. So 3D mapping is way superior and safer for the patient, and you get more accurate information. So coming back to the differentials in the broad complex tachycardia, it is SVT with aberration. You can have pre-excitation with antitropic tachycardias. We discussed on different, through the node, through an additional accessory pathway, bystander pathways. These are more technical names to say that a pathway is involved with the tachycardia. And mainly the VT. Now, the current situation about VT is we can not only try and partially prevent it with medication. Ablation is far superior to medication. Okay, that's, just take it home. It's been proven repeatedly. And we have the technology here to safely ablate VTs. If you want to treat VT, there are two things you want to keep in mind. One is to bail a patient out. And the second thing is to prevent a patient from having VT. To prevent a patient from having VT is a different game from bailing a patient out. Bailing a patient out is your ICD, and preventing a VT from happening is by medication and by ablation. These are the only two things. No matter how many ICDs you stick in a patient, it's not going to stop a patient from having a VT. And the same thing with VPCs. VPCs, ICD actually does nothing to the VPC. You want to ablate them or give them medication. And when you, if you're compelled to give an ICD for a patient who has VT plus difficult problems, then you give medication. You see, medication, mainly two medications. EP is very simple. It's like a non-pharmacological treatment generally. So give amiodarone and beta blockers. This is the combination which works for broad complex tachycardia. Amiodarone is a dirty drug. I don't like it. I mean, we give it because we don't have better medications to give it. That's a fact. Patients lose their thyroid, eyes. They look, I mean, if you've seen side effects of patients, they look like gargoyles with time. You know, it's just the skin goes disruptive, liver doesn't function well, and it's quite a sad thing. But if you're compelled, I mean, medicine is not perfect, and but EP can solve a lot of problems in patients who can't cope with amiodarone toxicity. This is the picture I was talking to you about. Left bundle is not a wire with like split thing. I mean, that's an artistic imagination. This is how conduction system looks with the Purkinje tissue in the left ventricle. Okay, this is dog, but we are closer to dogs on this, so it's not a problem. So it is, and you can imagine the amount of disease process which is needed to destroy the entire left bundle. If you have left bundle branch block, it's not a joke. There's something seriously wrong with the patient. Okay, so as far as the ectopics are concerned, thankfully, my previous speaker has spoken about it. The numbers you need to look at is just two, 10,000 and 5,000. If the heart is damaged, as evidenced by MRI, then 5,000 is a valid number. If the heart is, if MRI is totally clean, 10,000 is valid. Why is it valid? Because the heart starts getting weaker the more number of ectopics you have. There are patients, I have had numerous patients, 20%, 30% ectopy, no LV dysfunction. Okay, and they've had those ectopics coming from around the bundle of his. So I just backed off, young medico, when she was a medico. So I asked her, I said, do you want me to go ahead and take the risk and burn there or just back off? She said, no, sir, I don't feel anything, just let's leave it alone. So this is the 4th year, no decrease in the ejection fraction. So not everything happens in all patients, but the key thing is you want to be very careful and observe the patient. Talk to them, explain to them, just spill all the beans, or speak to the relatives, which is a brilliant strategy in India. You must talk. You may be getting sued in England, but here you have to talk to the relatives. Otherwise it doesn't work well. So radio frequency ablation using 3D. 2D, as I said, is like auto rickshaw thing. It is good for SVT, it's good for thing. And 3D is based on 2D. It's not that 3D is jumped out of the planet Mars or anything. It's just an evolution, but it is a scientific evolution. So if you have better tools, why would you use suboptimal tools? And we have the technology here, and it is affordable. I'm saying it with a bit of thing for patients who are covered, and we'll try our best to try and make it affordable by doing certain adjustments. But this is the safest thing. If I had to have an ablation, if Dr. Deshpande is going to do my ablation or Hemant is going to do, I'll just do it on 3D. It's like, please don't jab me with so many catheters with all this radiation going on everywhere. So this is where we are. And as far as VT ablation is concerned, stable VTs are considered ablatable. Unstable VTs you can ablate successfully. And VF is ablatable as well. So if you have a VF, how do we ablate VF? Not when, what we track is the first beat before the VF. So we track that, localize, one beat is enough to localize which part of the heart it's coming from, which ventricle. So we use that to track and pin down that area, and we burn that particular ectopic. And once that ectopic goes away, the trigger for the VF goes. So that's how we do it. And we do it under extreme circumstances. I've done VT ablation in patients with extracorporeal circulation. All this depends on how they come and what is the situation of the patient. So this is 3D mapping is nothing but a radar thing. So it creates, we place patches, create a electrical or impedance field. Generally, you have magnetic field as well. And when the catheter moves up and down or this way or that way, it creates a differential. It's a very mathematical thing, so I wouldn't want to bore you with all those things, but you can understand that if this wire is moving, it can track based on, if it is moving here, the signals here are more than here. That negative differentials is what, in a 3-dimensional space, tells you where the catheters are moving. It's very useful, and it is safer for the patients, and it helps cure arrhythmias better than 2D ablation. Sorry, I had to rush through the whole thing. This is this is electroanatomical mapping, where if you look at this, this is a scar of a rabbit heart, and when you do electroanatomical map, you take electrical pictures of the scar. So this is the dense scar, and the borderline of the scar where the VTs occur, you see there's a heterogeneous thing, green and blue and yellow. These are the voltages at those particular areas. This is far superior to MRI. If the MRI doctors say, oh, no, it's all clear, there's no structural heart disease, and you go in and you put the electrical catheters there, there will be differences. So this is far superior to MRI, but you can't do electrical. You don't want to push catheters into all patients all the time. So this is electroanatomical mapping of a scar. And I'll show you a quick, this is a patient who had VT, okay? So this is the substrate, they found out that these are border zone. And here's the VT trying to break into the scar. And so this broke into the scar here, so we identified what's called as isthmuses, and we got exit areas. And by burning. Ablation is nothing but creating roadblocks by burning using radio frequency energy. Basically, it's that. And once the roadblock is created, then the re-entry, that is by which I mean dog chasing its own tail, dog no longer smells the tail, so it lets go of chasing. So that's your breaking of the re-entry circuit in VT. Okay, so this is not just theoretical gaming. This has dramatic changes in the survival pre-2009 and post-2009. So VT ablation, VF ablation, these are real-world stuff. Nothing I said today is theoretical. So broad complex tachycardias are, it can come from any part of the heart. It could be atrial arrhythmias, it could be ventricular arrhythmias. Most probably they will need more advanced technology like 3D mapping. And so don't worry, bog yourself down into the individual diagnosis. Sort out the patient's issues, treat the patient, send the patient to us, we'll work things out and we'll tell you what's going on. We'll show you those pretty pictures in your patient as well. So, I think that's all I have. Any questions?
Hello. So I would like to ask one question. That every rhythm you use a 3D, or the certain things like AVNRT or atrial flutter, that ablation might not require a 3D. So what is your preference in using a 3D mapping to an 2D mapping?
See, in India, the blunt truth is cost. Okay, in the West, it doesn't matter. Nobody looks at the bills. Okay, we don't even know what. So now, truthfully speaking, for simple, narrow, complex tachycardias, 2D is sufficient. By which I mean we are not, the distance to go in that auto rickshaw is not far. Okay, that's what I mean. But if you want, say if it's a atypical AVNRT, or you have previously failed AVNRTs, because not all AVNRTs are like, 99% success and all that. You have, my first AVNRT, I can tell you, it came from the left side, okay? It was coming from the left atrium, and I couldn't believe it. I said, this is my luck, I'm starting in India with this kind of a case, which is 6% of AVNRTs. So for these kind of cases, you can keep looking for them, or till cows come home, you're not going to get anywhere. So in these patients, it's a judgment call at the end of the day. So simple cases, 2D is sufficient, amply sufficient. Okay, say if it's a free wall pathway, if it's a standard AVNRT, or if it is a flutter also. But the advantage with 3D is no two flutters are the same. If it is a non-CTI dependent or partially CTI dependent, so any more than safe travel with a rickshaw, that's 2D sufficient. Any more than that, you need a 3D. For, again, safety, time, and efficiency. So if you, and another thing which I learned from Chennai guys is that they use 3D for all cases. So in that, say if they're going to do 3 or 4 cases, they use the patches which are external. So you rip it off after the case and you put it on the second patient. It's nothing internal. So they bring down the costs per patient that way. So a VT patient gets his patch, and the same thing, a patient with AVNRT also gets a patch. I mean, they sell it in a different way, but this is what they do. So there are ways to, but it's a gray zone. And they are real die-hard 2D ablators, especially from, so they will say everything in the world can be done by 2D. It's not wrong, it's not false. But as I said, you can, the way you want to travel to Bombay also it's not like false or anything, but it's a way of doing it, comfort zones and training. Most of my cases I did in 3D, so I'm more comfortable with that. So I hope it answered the question. Is there?
In patients with structural heart disease, like Brugada's or maybe right ventricular dysplasia, when you get VTs and all, then how do you proceed? Whether you go with medicines or you try with ablations and all?
See, it depends on how the patient presents. if a patient presents to you with a syncope, young guy with a syncope, and first of all, I send them for, I have very low threshold for sending up for MRIs. Okay, I almost tell, please do an MRI before I even look at it, because that substrate information is critical precisely to strategize the entire thing. So I had a young guy who came with, on the ECG it looked like coming from the right ventricular apex. He was 34, IT guy, feeling dizzy. That's all was the thing. Echo was normal. So I said, no, you don't get ectopy coming from right ventricular apex because that's not a normal area to get ectopy from. And I said, this guy might be having something more. So when we sent him for MRI, they didn't show classical ARVC changes, but definitely apex did have early changes or the slightly increased scar in the right ventricular apex. So I told the cardiologist, I said, look, you just put an ICD in this patient, initial part, okay? We'll give him medication, see how it. First, you want to try and give him safety net. Okay, that's why I think I know the vagaries of what we can, and when 70% is the cure for VT ablation, and a patient has a progressive disease like this guy, so would I not give him a safety net? So will I? So what phase will I tell his wife? Yeah, look, I'm going to do a VT ablation. It'll cure everything. But I know ARVC is incurable disease, and if he's extremely lucky, then the progression stops. You want to understand the disease. But if it's a Brugada, then you can probably get away by an ablation if you're able to localize that. So, and what kind of Brugada? Is it like fully manifest one, or is it you have to give a lot of flecainide to bring it out? So all these things, you want to subcategorize them, but my view is I go for safety. I mean, it's probably a little British bug in my head, but I don't want, I'm not a jockey that way. Okay, okay, thank you.
Thank you, sir. I would request the panelists and the chairperson to felicitate our speaker, please.
This is it. Oh, thank you. Thank you for having me. It was our pleasure.
Thank you, everyone. So we'll take 5 minutes tea break and then we'll join back for other sessions. Thank you.
bradycardia is defined as if the heart rate falls less than 60 normally, but most of the time they have become symptomatic if they fall less than 50. Some of the definitions are given less than 60 and some of them are given are 50. So this is very important to understand because bradycardia causes more symptoms than the tachycardia. Now normally look at this ECG, the upper ECG heart rate is 75 beats per minute. The lower one is almost 40 to 43 beats per minute. So this is a bradycardic ECG. Now why this bradycardia? This is very important because bradycardia directly pulls down the cardiac output. And because you know that cardiac output depends upon the stroke volume, the heart rate. And theoretically, if you look at the slower the heart rate, we feel that diastolic filling will be better and will be a good cardiac output, but generally that is not because diastolic filling, which let contribution to the cardiac output, when the heart rate goes down, the cardiac output drastically comes down. One need to know that progressive bradycardia is very important to watch because suddenly patient heart rate will be 50, then after sometimes it is coming down to 40, 45, then 30. That is a very life-threatening. Suddenly patient can go into the arrest. Sometimes this bradycardia is so low that it can trigger the tarsa-DD pontis. That is very important to understand because some of the time this prolonged QT interval, the vulnerable period of the heart will fall and the T wave R and T phenomena can initiate a tarsa-DD pontis which can immediately go into the cardiac arrest. Now this is an tarsa-D, this is a bradycardia. Patient has got a bradycardia. You can see that heart rate is very low. All of a sudden, the R wave falls on the T wave and initiate the tachycardia. This is what happens if sometimes the patient can present you in an emergency as a tarsa-D pontis. Then in this case, you need to shock immediately. Then later on, we know that this patient has got underlying prolonged QT interval. That is a cause for this bradycardia. The prolonged QT interval, we can evaluate what is the cause. Now, etiology, come to the etiology, there are so many causes for the bradycardia. Most commonly we come across is a medication. Patients has been treated with some other disease. Will have a beta blockers or the digoxin, other antiarrhythmic drugs. Sometimes they give an overdose or sometimes there can be a side effect of these drugs. Or patient taken by mistakenly some of the drug 2 times or 3 times unknowingly. And the other causes will be the metabolic. We face a lot of problem with the electrolyte imbalance, especially hyperkalemia and hypermagnesium and hypocalcium, all hypo-related electrolyte these things. Sometimes patients can have a renal failure. In that patients who are taking beta blockers or AV nodal drugs can present with a brush syndrome. That is bradycardia, renal failure and AV node blockade with shock and hyperkalemia. The other causes commonly will come as is a myocardial infarction. You can have an inferior LMI is because this is an RC. You know that RC, right coronary artery, is in a supplies the conducting system. Any of the infarction to the right coronary artery can present with various conduction disturbances, including bradycardia. And anterior wall MI associated with bradycardia is in a very worse prognosis because the large amount of the myocardium and the conduction system is involved. Invariably, these patients can go into complete heart block, may require some of the treatment. So other neurogenic manifestation varies. It can be asymptomatic bradycardia that does not require to be treated, or it can be a stable bradycardia, can have any symptoms, or it can be unstable bradycardia where requires immediate attention, or bradycardia can just prior to the patient can worsen, it can be in a peri-arrest, or can go into cardiac arrest. So one has to be very careful which situation you are going to face in the emergency department. So coming to general approach, the principal management remains what is what is causing always bradycardia. Now always remember that there is a life-threatening bradycardia, you always treat immediately. Sometimes bradycardia can be a normal in a situation like in a sleeping you have an heart rate is low, or in a kind of athletes you have an heart rate very low. So that does not require to be treated. Only when if it is abnormal bradycardia, if there is a bradycardia associated with other diseases like an hyperkalemia or drug toxicity and myocardial infarction or neurological disorder like rise intracranial tension can immediately require treatment. So determine the bradycardia is stable or not. First step you have to take in a ER, is the bradycardia is stable or unstable bradycardia. Now you have to go through the history. What is causing history? Is a low heart rate associated with any symptoms or not? That decides your course of management. This is a patient where came to me on, she was one of my railway employee was sent to me ECG. This is an ECG. If you look at this, it is extreme sorry. If you look at this heart rate is very low. And she presented to the physician, then physician immediately realized that and told that she requires a pacemaker implantation because heart rate is low. And then this ECG was sent to me that evaluate this case, what exactly is went wrong. Then I asked her, do you have any symptoms? She says, no. What did you do morning? And I asked her, she said, I ran for 21 kilometers today morning. I came, nothing is that. Then we looked on, she's got hypervagotonia. She is an athlete who runs marathon running and she runs daily 10 to 20 kilometers range and she absolutely asymptomatic. So this is hypervagotonia induced bradycardia. It does not require to be treated. Then we asked her to stop running. Then now she became all right. Her heart rate is normal. So one has to be careful. And what is the hemodynamic status of the bradycardia? Whether the symptomatic or asymptomatic, and these are how the steps one should go through the bradycardia presenting patients. This is very important. Some of the time you need to know that what is causing bradycardia by looking at the history and all. If you have a metabolic problem, especially electrolyte imbalance, you should immediately treat. If you have drugs, if there is a history of drugs consumption, you need to stop the drugs inducing the bradycardia, and you have to evaluate for the manifestation of the myocardial infarct, or if there is a neurological one, need to go there quickly. And evaluation of the hemodynamic status is very important. You go through the history. Suppose if the bradycardia associated with the symptoms of hypertension, low cardiac output, or there is an hypoperfusion of the coronary arteries presenting with ischemic chest pain or dyspnea, these patients immediately requires to be treated. Usually the symptoms results, one time you have to be very careful. Is the symptoms related to bradycardia or the symptoms presenting the bradycardia? Like vasovagal bradycardia, that is basically pain-inducing bradycardia does not require to be immediately treated. That does not require a treatment of the bradycardia. What is causing vasovagal syncope or vasovagal bradycardia is need to correct the underlying this thing. Whereas bradycardia causing the symptoms then requires to be treated bradycardia. Now this is how they suppose if the in ER comes with a near almost going to arrest the patient, one need to evaluate this patient thoroughly, and management remains electrical and mechanical, and plus medical treatment. You simultaneously you start pacemaker. See, you cannot immediately start the pacemaker ER. You have what you call the external pacemaker. You can put an external pads and you can pace the patient, and immediately at the same time you can give the medication, and immediately you can give the inotropic drugs or atropine, and if there is an electrolyte imbalance, you collect with the electrolytes, and if there is an hyperkalemia and all, you give the calcium gluconate, other medication, and once patient is stabilized, once everything is done, suppose if still he is in a bradycardic and he requires to be, then you send him for a pacemaker, transvenous pacemaker, and subsequently evaluate what is the underlying thing, treat according to that, whether he requires to be correctable one or not correctable or require a permanent pacemaker. Now, these are the calcium responsive bradycardia. So you have an hyperkalemia, you give the calcium gluconate, immediately get corrected. Hypocalcemia and hypermagnesium and the calcium channel blocker overdose also, and beta blocker overdose, so you can give the calcium IV. Now, what is the symptomatic versus second symptom, asymptomatic? Now, if I told already, if there is any symptoms, you need to be treated very early, urgently, and the bradycardia as a result of vasovagal does not record, and if there is a symptomatic bradycardia, then you need to evaluate what is causing. Is it low heart rate or the patient is symptoms, and the symptoms are related to that low heart rate. That is very important to analyze in a ER. Asymptomatic bradycardia generally does not require a treatment. And determine where is the site of block. That is very important. Once the patient is stable, you need to know that where is the site of block. You know that the blocks can occur anywhere in the conduction system, starting from the SA node and their generation of the impulses, or exit from the SA node, or it can be a block at the level of the AV node, or it can be a block at the His bundle or down node. Anywhere block can occur, one need to evaluate and find out whether the given rhythm is stable. Now, usually SA nodal and SA nodal block, usually they are narrow QRS complexes, so they are usually stable rhythm, does not immediately require to be treated immediately, but the bradycardia originating from the lower down, usually they are unstable rhythm, they have a wide QRS and requires to be treated. They won't respond to the atropine and inotropics, you need to treat with a pacemaker. or either transvenous or the permanent pacemaker, this patient depending upon the cause. This is anatomic location. You can see that here is a narrow QRS complex. Majority of these blocks such as SAAV node, they present with a narrow QRS complex bradycardia. One can wait and see, evaluate what is causing and does not immediately require to be treated, whereas other side where there the wide QRS bradycardia requires to be treated immediately. And these are the causes. I told you these are the causes. Can be sinus node dysfunction. At the sinus node not generating the impulses, or it generates the impulses but they have an exit block. It may not come out from the sinus node. Then subsequently the other node, lower node will take over. So sinus node can have a sinus node bradycardia, no impulse formation or exit block, or it can have pause, arrest. Sinus node does not produce at all, can go for more than 3 seconds duration, pause, then it is very significant. Or it can have an AV node block, you can have first degree, second degree, third degree, depending upon the manifestation, one can find out the ECG. Usually first degree is a prolonged PR interval. Second degree, you have one of the beats will be missed in between and second degree, again 2 types you have. On the type 2, Mobius type 1 and Mobius type 2 block, they are Mobius type 2, usually it will be infraesion, most of the time requires to be treated, whereas Mobius type 1 is a narrow almost, it is an AV nodal block, unless it is associated with the bradycardia or the wide QRS complex, one need to be treated. Rest of the things, high degree AV block where there is no complete dissociation between the atria and the ventricle, manifestation a complete block, you need to treat. Bundle branch plaques usually does not require unless they have an association with money, 2 or more, 3 bundles are involved, presenting with the bradycardia requires to be treated. This is a second degree AV block. Second degree, this is a second degree Mobius type 1. You need to see that the pre-R interval gradually prolonging. After sometimes you get in one drop, there is a atrial contraction, but that is not transmitted to the ventricle. So this is a Mobius type 2. Usually this is most of the time they are wait and watch, you can treat according to what is causing it. But whereas Mobius type 2, you have an impulse, there is no prolongation of the PR interval with the subsequent beats, but the 1 or 2 beats after the atria is contracted, but they are not transmitted to the beats. You have 2 or 3 atrial contraction, but not transmitted to the ventricle. They form into the high risk group. These patients usually required to be treated immediately. And usually they do not respond to the inotropic drugs and pacemaker. Then your pacemaker is in a treatment modality. And this is in a complete out block. You see that there is no correlation between the atrial and the ventricle. The atrial beats its own and the ventricle beats its own. And these are the patients. You see the atrial rate is 130 somewhere and ventricular rate is 37. These are the patient does not respond to any of the treatment. You need to evaluate and treat with a pacemaker. So investigation comes. You need to do all the blood. One is ECG. Of course, ECG will tell you about any electrolyte abnormals, any prolonged QT interval, anything. And or any associated ischemia, anything you need to treat, and otherwise you do some of the status, you give the volume. Suppose if there is a sometimes there is a depletion of the blood volume or bleeding, internal bleeding, can have a hypertension, bradycardia. One need to evaluate in a ER apart from the ECG and the investigations. And lab investigation includes all the things you have to do. What are the precipitating causes? You know all the things. One need to evaluate for the MI, presenting this. It's history-wise will tell you which investigation is an ideal for a given patient. And treatment comes to the asymptomatic patient, no treatment required. Symptomatic patients, immediately if there is this, you give an atropine. You can give an atropine 5 milligram push. Every 3 to 5 minutes, you can give total 3 milligrams total dose. And if there is any other medicines causing etiology of the bradycardia, by looking into history, you need to stop some of the negative inotropic drugs, or if there is an hypokalemia, replace it. If there is a hypothyroidism, yet to be treated. Pacemaker, if the patient is continually symptomatic with no improvement with this thing. And if it, of course, this is related to the particular cause. If it is myocardial infarction, treat the myocardial infarction, and it may subside the underlying bradycardia. If it is medication related, you have to stop the medicine. If unstable bradycardia should not be treated directly, if left treated hemodynamically can worsen the unstable bradycardia can spiral down out of control, and the lack of perfusion further impact in the cardiac blood flow. So decreased perfusion to the brain can lead to the stroke and dizziness and confusion. One need to know very well. So there are 3 ways of stitching. Immediately you correct the fluid blood pressure, increase the blood pressure by giving the fluids and inotropic drugs, and which constrict the peripheral blood vessels and raises the blood pressure and increase the heart rate by giving an inotropic drugs. And all the 3 treatment modalities should be carried out in a serious emergency situation. And in case immediately you cannot put then a pacemaker transvenous, you can put an external pacemaker, and immediately it can be put on a ER and look for the patient and stabilize the patient and shift him for the transvenous pacing. Second comes in case, in spite of that, all the medication is not responded, then you take the patient for a transvenous pacing and subsequently evaluate the patient what is causing for the bradycardia. If the patient required to be treated, then you need to look for the permanent pacemaker, especially sinus node dysfunction, AV blocks, and neurally mediated syncope and post-ablation. Some of the cases where during ablation we can have an AV nodal ablation, so the patient can go into complete outback required to be patient. So pacemaker comes, you need to, it's all depending on what is causing the site of block. So you can have either atrial pacing or a ventricular pacing, or you can have dual chamber pacing, physiological pacing. So with this, I'm going to stop my talk, and if any question you can ask. So be cautious about history and physical examination. That is very important. You need to examine the patient thoroughly. You need to take a physical history, because that gives a clue what is the underlying cause for the bradycardia, whether this patient required to be immediately attended or treated fast way. So look for a ECG, whether they're narrow QRS bradycardia or wide QRS bradycardia. That is also gives a very important thing. And you need to know that tachybrady syndrome, because tachybrady syndrome is where there is an excessive tachycardia followed by bradycardia. These patients are very careful, because giving the drugs to control the tachycardia, they can put the patient into bradycardia period to more worsening of the heart rate and symptomatic. This patient requires to be put a pacemaker and treat the tachycardia. So and rule out the currently secondary cause of tachycardia. Thank you.
Thank you, Dr. M.V. Reddy, for this detailed and useful presentation. Any questions? So, yes.
So, very interesting and very elaborative talk. Thank you, sir. So, another just one point from my side, since I am an intensivist, basically most of the times patients who are coming to the ICU, particularly the viral infections and tropical infections like dengue, typhoid and COVID, we see a lot of these bradycardias actually. So just I want to ask one question, like what is the role of these ORC-based tablets, which is now available rampantly, and what is the role actually?
I know, see, basically what is recommended is, if the symptomatic bradycardia only you have to treat. Viral infection or all these things causing bradycardia, if the heart rate is low, patient is asymptomatic, usually does not require to be treated generally. Suppose if you feel that this patient, one thing is you have to watch this patient. Bradycardia may be 40, 45 in the morning, then after some time you come and see it is gone down to the 40, below 40. They are the impending arrest. These are the patients where you need to start the medication. Otherwise, stable rhythm, absolutely asymptomatic patient, treat the underlying cause, usually they recover. There is no need of pushing them into the giving inotropic or oxyprenone or isoprene drugs and keeping the heart rate unless they are symptomatic. But cautiously you have to watch this patient worsening bradycardia. You have morning you have seen him, patient is on 50, then after some time you see him it is coming down to 40, then the chances that he may go down to 30 and he may arrest also. That is very important. Watching in ICU very carefully these patients. Only symptomatic treat them, otherwise not.
Okay. Just point to add, in my practice, we are seeing this bradycardia patient in 2 sets. Either young female with increased vagal tone causing bradycardia, and another is elderly female who are receiving antihypertensive in form of beta blocker as a first line of treatment in combination. So just to do a note, now beta blocker have been pushed as a 5th agent of choice. So for any antihypertensive patient without any other indication please don't add beta blockers as a first line of treatment, especially drugs like atenolol, which has shown to be very poor antihypertensive, and it increases the central aortic pressure and increases the risk of stroke. So this beta blocker has to be reserved in the patient of hypertension for other patient with other indications like angina. So these are the things.
Most of the time we come across bradycardia, most of the secondary bradycardias. Patients who are on negative inotropic drugs for blood pressure or antiarrhythmic drug, these are the patients usually they have low heart rate. I think you need not to hurry up and treat the bradycardia part. Stop the given drug and wait for that. If they are asymptomatic, usually they recover.
Just a small note on the Orsibest thing. Don't trust Orsibest. It works when it works. It doesn't when it doesn't. And it can stop working whenever you don't expect it to stop. So that's the nature of Orsibest. You can give it, if you want to buy time and you don't have anything else, you can give it for the want of nothing.
It's like slogging a dying horse.
You just don't trust it, and you want to plan definitive treatment for the patients, not banking on Orsibest. Even if say congenital heart block or the patients who have been having these slow heart rates for donkey's years, and you see them on in an OPD basis, and you're shocked. But giving Orsibest, it becomes tachyphylactic very fast. And with time, whether he takes Orsibest or not, the heart rate remains the same. And so it gives you a lot of false hope, and it's not reliable. In fact, we just don't encourage it, but there are situations where you're forced to use it for want of something better.
So what about theophylline derivatives like
They're
in
all the
AVD?
same
Yeah.
They're all high tachyphylaxis thing. Yeah, you want to plan for the definitive treatment. Don't depend on this, and give it because you don't have anything better. That's fine. What do you say?
You can use it for 2-3 days to tide over, then it will develop tachyphylaxis. That is one. Second one, I wanted to know bradycardias, how to wait. This is a question we used to ask in dengue. At what level we should give platelets? When we started practice, it was 50,000. Now we come to 10,000. To wait till giving platelets. Same thing we see bradycardias in dengue, where we have seen bradycardias to the level of 36, 40. When you tell us that you wait and observe, it is very difficult to wait, take the patient in the hospital from room to ICU and don't do anything. So at what level of bradycardia in dengue we would like to treat bradycardia?
I don't know.
Most of the patients are asymptomatic, but we cannot see the patient dying. If it goes, as you said, if progressive bradycardia can lead to arrest.
I understood that.
Then what level we should intervene?
See, there is no clear-cut guidelines are given. Particular level you have to start giving medicine. What is given is
why I'm saying
symptomatic or asymptomatic. If there is a bradycardia 35 you are worried about, I think these are the patients should be very carefully kept and watched, because they can have a progressive bradycardia and arrest.
I'll tell you. In dengue, government guidelines say 10,000 is a cutoff. Whether you have a symptom or no symptom, you give platelets. If you don't give, it is a criminal negligence. If I watch my patient of a bradycardia in dengue, say 40, I take him in the ICU, don't do anything because he is asymptomatic, and he goes into arrest and I cannot revive him because might be he has underlying myocarditis, shocks may not work or they can kill. Is there a medico-legal liability for all this? Is there a guideline to say that XYZ level you start treating bradycardia?
I don't know. Yeah, I think.
Dr. Mantra. See, one thing. Okay, so let's look at a young guy. You want to? I'll give you a young patient who's got dengue. He's just trying to recover from it. He's got bradycardia because of dengue. All that is fine. Now, if first question you want to ask is, one is symptoms is very clear. Let's assume that this guy is asymptomatic. Oh, yeah, fine. So now in this situation, what I would do is, I would get a halter, make this guy walk. He can walk, right? So if you make him walk, you'll know the chronotropicity. If he's chronotropic and he's able to hit or make him climb stairs, if his LVEF is okay. Yeah, so you put him on a Bruce protocol. Yeah, so what you want to do is, you want to see if there is acceleration or not. And one of the indications for pacing is irreversibility of the underlying condition. So if a condition is reversible, you wait for the reversibility to go in. So now you're saying, okay, this guy may just die on me. That's basically. Yeah, so normally it takes at least 6 to 8 weeks. It is a very difficult period to watch over because autonomic dysfunction sets in. And see, if we all have dengue and we have autonomic dysfunction, Charan's dysfunction will be different from yours, will be different from mine. So if resting, say at sleep, it is more than 3 seconds, pause. 3 seconds pause at sleep. Then you may want to start talking to the patient's relatives about it. And it depends, again, I think the most brilliant statement in today's entire talk is talking to the relatives. Talking to the relatives. In India, that is the best advice you can give any medical student, any doctor, any specialist, anybody, because there are situations where you can't control everything and things can just fall between your fingers. In those situations, you just get everybody together and you discuss. So you'll, at the event, at some point, you will get a way out of the whole thing. If he is struggling, so if this guy is, you do a Holter, pre-discharge Holter, definitely I would suggest. Okay, you can do a stress test if he's fit enough to go for a stress test.
Stress test, I think that is ideal. Immediately you can subject him to stress.
So 3 seconds, 3 seconds at night. Yeah, but we can't play God now. We just. See, the level of heart rate is an arbitrary thing. So when I give beta blockers to patients, I tell the patients not to worry unless it goes below 50.
It's like end-developed age. So
Yeah, so, yeah, correct. So, correct.
What I will do for myself.
So you use a pulse ox, keep watching it. So no, if your heart rate doesn't, if you're feeling giddy, you have to wait for it. Unless you say, look, I like to have this nice toy, which is a pacemaker, and I like to, it's a nice thing to go on with, then that's a different story.
So there is no medical legal liability. You want that, right? You don't have.
When I was in US, and my heart rate was 34, and I was like, oh, is that my heart rate or is it somebody else's? I thought maybe the leads went off. Nothing. It was sinus rhythm, and I was watching my heart rate. So they suggest, and I was not feeling giddy. My blood pressure was okay. It was 90. Okay, to tell you more, make it more real. So I just waited. I said, I don't want this metallic stuff sticking into my heart for something which may just recover with time. So there's no hard and fast rule, but this is where the clinician's judgment comes into prime focus. Yeah, Ossibus, as I said, Ossibus is an excellent thing in this situation because...
I think that is sometimes relative indication.
Ossibus is deep consolation.
I just request the discussion to be kept bradycardic only because we are losing time. Yes, sir.
Draw a line on that.
So that's a sir has told that up to 50 we accept the heart rate.
No, apart from monitoring the heart rate, how long do we still go on continuing? Beta blockers are continuing almost lifelong. Yeah, that's what I'm just asking. In view of this fatal arrhythmias that can set in.
Sir.
Why is he continuing in such a situation like
Whether there is bradycardia is not as dangerous as having a VT.
Sir, in the
Bradycardia is not as dangerous as having AF and stroke. If a patient can manage bradycardia, I'll take it any day. You can always reduce the dosage. You can reduce the dose, yeah. But you don't want to fear bradycardia unless it is really critical.
and that criticality is what you want to really look at. It's a thing. I will take bradycardia with both hands, both knees, if I'm going to risk a VT, because the best drug for VT is not amiodarone, it's beta blocker. It's beta blocker. So that's the only thing we have in anti-arrhythmic.
So as per the current guidelines following coronary artery disease, 1 year we have evidence that up to 1 year it has to be given. Following 1 year, it depends on the LV function of the patient. If there is an LV dysfunction, we continue it lifelong. However, if there is no LV dysfunction, the current evidence is only up to 1 year following an ACS that we need to give a beta blocker. So that's how it is. That is what is given in the guidelines. So tennis players, we expect bradycardia, right? So athletes, we expect bradycardia. So that is something which is expected.
Thank you, MV Reddy sir, for such interactive discussion. Next, our speaker is Dr. Sanjeev Kumar Kalkekar. I would like to invite the chairperson and the panelists, Dr. G.R. Kane, Dr. Shilpa Kadam, Dr. Vinay Shelar, Dr. Samir, Dr. Chandrakant Shinde.
चल नहीं रहा है चलत नहीं नॉट कनेक्ट
तुम्हें बंद के लगा
नहीं कुछ नहीं किया अभी देख
No.
My situation is like a last batsman have to score like 100 runs and only 4 or 5 overs are remaining. My colleagues has lot of taken time, so I will not take more times. Those who have developed bradycardia, this is for those. Or those who are dosing, this is for those. So I start my topic with one of my patients. This is a 75-year-old male presented with non-elevation on venti with inotropic support, creatinine 2.14, hemoglobin was 6.6, left lung collapse, partial palatal palsy was there, bad sepsis, and long-standing hospitalization, and he had problem with minor surgery like tracheostomy. And now this person developed complete heart blocks. I think no cardiologist likes such a combination of diseases to have with them. And what was the treatment for this patient? Yes, you had bradycardia. The treatment is putting in permanent pacemaker. Now, already my earlier speaker has given the way that when you put in a permanent pacemaker, we need to do surgery below the clavicle bone. And by doing surgery, we have to pacemaker like this thing and connect this lead to the heart. So if you are putting a single pacemaker, a single lead is called as a single chamber pacemaker. And if you do a double leads, we call it a dual chamber pacemaker. To remind again, my problem was patient doesn't want any surgery because he had bad experience with minor tracheostomy surgery. What to do? My another patients, again complete heart block, advised permanent pacemaker. Left subclavian vein was used for dialysis. Right subclavian vein was used for chemotherapy. Now what to do? We don't have access to put a permanent pacemaker. Permanent pacemaker requires subclavian vein to be there. Again, one of the patient at Amritsar, earlier pacemaker was done. Now it is coming for the revision of pacemaker. Left subclavian pocket they used, but it got infected. So kept patient in ICU for 7 days and then done for the repeat pacemaker from the right side. Again, that got also infected. Due to multiple intervention, he doesn't have right femoral at all only. Now what to do? Patient is lying on the bed. Since last 7 days, he is dependent on pacemakers. One of the patients at Vadodara presented with 6 sinus, diagnosed as a 6 sinus syndrome, having neuropsychiatric disorders. So moves a lot, continuously movement is there. And again, difficult to put a pacemaker in such patients because at least they should restrict their physical activity. One more patient's status post mitral valve replacement, status post tricuspid valve replacement, both bioprosthetic valve were there. And this person developed complete heart block on day 7. Relative doesn't want any kind of surgery. Again, there will be a transvenous catheter across the newly formed wall, doesn't want anybody. What to do in such patients? Just imagine this beautiful lady has come and wants pacemaker and doesn't want any scar over her chest. Just imagine. This is not the real patient. So what to do? So this is a pacemaker. Pacemaker has evaluation from that. Earlier pacemakers were like they are implanted externally. The development of it come implanted internally below the clavicle bone. Earlier pacemaker were emotionless. Whatever happens, heart rate is 60. So now they made in the rate responsive pacemaker with increasing activity. Their heart rate was also increasing. Earlier pacemaker problem was that they cannot do the MRI. The newer pacemaker can't do the MRI. Pacemaker has battery life has increased. Technique, though technique is same, lot of improvement occur, but all these improvement are not important for the patient which I mentioned earlier. So what is important is a leadless pacemaker. So the leadless pacemaker, a new star in horizon. What is leadless pacemakers? This pacemaker doesn't require surgery. So once they are out of surgery, there are no pocket related problems with these pacemakers. They don't have a lead, so no problem with the leads also. So these are pacemakers can be directly implanted into the right ventricular. So these are called as the leadless pacemakers. They are 93% smaller than the actual pacemaker. The size is this much, just like a vitamin B12 capsule or misal the bullet size pacemakers. So what are indications for such pacemakers? Anatomical issues where thrombosis is there, TV leads are there, indwelling catheters are there, hemodialysis patients are there, risk of pneumothorax is there, congenital anomalies there, kyphoscoliosis there. Infrequent pacings. Person requires pacing once a while. Why to want to doing surgery and put a pacemaker there? Again, complication with transvenous devices, which I already described. Then infection risk. Those who are patients who have high infection risk can go with such pacemakers. Age, elderly patient, dementia, young patient, where preservation of vascular is very much important. Cosmetic, patient doesn't want any surgery, like I shown you. Occupational, patient doesn't want any restriction of his movements. Lifestyle, psychological. There is one syndrome called the Twiddler syndrome. People have tendency to just touch this pacemaker and scratch it. One of my patients bring the pacemaker and showing, sir, ye bahar aa gaya hai. So thus tendencies are such patient, this is okay. So how the procedure is done? This procedure requires a 23 French sheath. Inside 23, outside 27, done with the right femoral approach. And this is a catheter which is used to implant the pacemakers. I already showed this pacemaker. What may be the weight? Weight is 2 gram. And size, I already showed this size is hardly bullet size pacemakers. Lifestyle, this will work for 10 to 12 years. And newer pacemaker, which will be maybe come in the market in next 3 to 4 months, a single chamber pacemaker will work for 16.5 years. A dual chamber micra will work for 15 years. Now, why this need for micras arises? We know that lot of pacemaker related, lot of pocket related problems and lot of lead related problems are arising, and this incidence was near about 12%. That's why need arises. These are the 3 studies, Micra IDE study, Micra registry and Micra VRCD, which has shown the results that these pacemakers are safer. The IDE study showed that there is a 48% fewer major complication with Micra compared with the transvenous pacemakers, with the maintaining pacing threshold, with a better electrical performance and with a better RV amplitudes. Again, the registry with major improvement in the techniques, it shows that there is a 63% fewer incidence of complication compared with the traditional pacemakers. This was a head-to-head trial which shows that there is 38% reduction in the rate of reintervention and 38% reduction in risk of chronic complication with no difference in the all-cause mortality. Now the question is that transcatheter transvenous pacemakers are in dual form also. That means they have 2 leads, one goes in the atria, one goes in the ventricle. But what about Micra? Micra, till now it was a single chamber Micra which will sense the ventricle and pace the ventricle. But the dual chamber Micra has come. This will pace the only ventricle, but the beauty is that it will sense both atria and ventricle. That is what was newer advances in that part. And this was a study called as a Micra ACL-AV study. In this it was found that those patients who have a complete heart block, but they have a normal sinus rhythm, I may say that there is a good PV on the ECG, This patient can go with the dual chamber micra, or you call it micra AV, atrioventricular micra, and it is found that 93% AV synchron is maintained with the micra AV, and those patients who have a resting, this is at the resting and during physical activity, it goes to 79%, but it can be again managed with the optimal programming. Now the question may arise how the micra which is situated in the ventricle sense the atria. What you have to understand, there are 4 activities in the heart, S1, S2, S3, S4. We blank the S1, S2, we reduce the threshold for S3, and this accelerometer based pacemaker, they sense the atrial contraction. Once the atrial contraction is sensed, they give the ventricular loads. So this is the technique. So there is a lot of clinical evidence, lot of feasibility studies, performance study and real world study that micra is suitable, micra is good. So best indication for leadless pacemaker is first, if it is a venous issue, go for leadless pacemaker. If it is atrial fibrillation, where only we have to pace the ventricles, we do not use dual chamber pacemaker in those patients, micra should be the best indication and only indication, barring the cost. And one patient has a 6 sinus syndrome, ideally micra should be avoided. But again, if the patient has a normal sinus rhythm with complete heart block, micra again takes. So this was the first micra case done at Apollo during COVID time. That was a bad time. One of the indication for this pacemaker that we doesn't want to be beside the patients, because micra can done for the femoral and don't have to wait 2 hours regarding the pacemakers. And again, patient doesn't want to do. These are the all cases done at Nanavati, Bombay Hospital, Nashik, Kolhapur, Pune, again at Baroda, Raipur, INS Ashwini, one of the largest centers. We've done 7 cases there, Jupiter, then Pune, Amritsar, Kolkata, Pune. So why micra? Redefine patient experience. Patient will not have any scar, no skin bump, no physical reminder. There is less risk of infection, hematoma, erosion or no more. Eliminated lead-related complications, streamlined procedures, and one device solution for all the problems. Thank you. One more thing is that I have to thank you, all of you. There are something difficulties in life, like understanding math in school days, understanding ECG during MBBS, and understanding women before or after marriage. And EP is one of the things. We cardiologists also do not understand EP, but you came in such a large number. I really say thank you to all of you. Open for questions. Kitna deti hai? The cost for single chamber micra is 7.5 lakh, excluding hospital cost, and for dual chamber it is 9.5 lakhs. So around 10 to 12 lakhs. So similar complication which occurs with the routine pacemakers are there with the micra, though they are less. Pericardial effusion, a local complication of venous problem can occur with the micra. So it is a similar, it has the same thing. One may ask troubleshooting. One more question is, what after 12 years? When you put a regular conventional pacemaker, after 12 years we replace the battery. But what about micra? We do not replace the micra. We make it this off the micra and put another micra. Our RVV is slightly bigger. दिल बड़ा रहता है, 6-7 माइक्रा आराम से ले सकता है. We have to put like a pacemaker. Don't put micra like things. It will cover. Don't make more educated these people. So like we put, do not put congenital heart disease. If you want to AHD closer, don't put congenital heart disease. Put AHD, they will give the sanction. It remains in RV only. Yeah, that question is there, whether it sleeps or not. It never sleeps actually. And 99% success rate is there with the micra. 99.2% success rate. I myself done 26 micras, no complication. Till whatever studies had done, only 1 micra was embolized, and that was again recaptured and taken back.
Perforation with micra?
Yeah, perforation is there. One report is there with the perforation with the micra. It causes perforations. So we need to prepare, and routine pacemaker also causes perforation. So compared with the routine pacemaker, risk is very less. So routine pacemaker, if it is going 4, it is kind of like 1%.
One more. One of the indications you had said was patient was in sepsis.
Yeah.
So then you treat, or under antibiotic cover you will put in a pacemaker, or you will wait for the sepsis to recover?
So this is very good question actually. Now I have one patient in Solapur, I have to go. So this person got infected on the both the side. I told put this patient on the temporary pacemaker, wait for 7 days, let the culture, all this goes, and once you are afebrile, no problem, then only go for the migraine. It is always better to take precautions because this is the last hope for this patient. Next day. That is the beauty of that. There is no physical restriction. Outside India, they discharge on the same day, but we take 9 to 10 lakhs. We always think that at least give 1 or 2 days hospital meal.
So what routes have you used for introducing mitral?
Yeah, so the legally guided route is right femoral, but out of 26 cases, one patient, this one person doesn't have right femoral only. So I had to go from left femoral. There are reported cases, one done at Raipur, he gone from the vein also. Jugular vein, IGV, not subclavian. Jugular vein. Yes, yes, we can put one more micra. So ideally we can go to 2 to 3 also. There are animal reports done in one patient in India only. This person has a single chamber micra. Now person has become this patient has become very much wiser. So he had put a single chamber micra, and last year dual chamber micra came. He got himself understand this has came. He gone to doctor and told I have to put another micra. So he was put a dual chamber micra. Now, for mitral valve, no problem. For tricuspid valve, if it is a metallic valve, we cannot go there. For bioprosthetic valve, we can cross the valve, put the micra. Regular pacemaker. There also metallic, it is difficult. Those patients with LV dysfunction, what you have to understand, if you are planning for dual chamber pacemaker, if the patient has LV dysfunction, we find out that atrial rhythm is, atria is good, we can go for this thing. But those patients with severe atrial LV dysfunction, we will think that atrial kick is very much important. Or a person has an AV block along with has 6 sinus also, better go for conventional pacemakers. No, but for atrial fibrillation, there is nothing like dual chamber pacemaker. You never go for dual chamber pacemaker. If you are putting a single chamber pacemaker, go for micra only then. And earlier micra were used to implant at the apex. Now we are putting in the high septum only. So again, it is giving narrow complex. In the era of when you are thinking conduction system pacing, we are also upgraded our knowledge and we are going up with the high septum only. No. Just by visual things. That's called as a hold and pass test where we have to put a micra, check the parameters and then go accordingly.
Can leadless pacemaker be used in a pediatric population? Above what age you will like to use it?
There is one study which was implanted at the age of 8 years. So this boy has complete heart block and they were planning for permanent pacemaker, then that all parameters, surgery will be there. They put a micra, and what may happen that maybe after 12 years, this 8-year child will become 20 years. And that time they may put a conventional pacemaker or they may put another micra also. So choices are there. Once implanted micra, we cannot go to another thing. That is the truth.
That was a wonderful presentation. Thank you for sharing the knowledge.
Thank you, sir. I would request the chairperson and panelists to felicitate our speaker, please. I would like to invite our next speaker, Dr. Hemant Kokane, on the stage. Chairperson, Dr. Harshit Lahoti, Dr. Bagul. Panelists, Dr. Bhai Mangesh, Dr. Anand Mishra, Dr. Aditya.
Short but sweeter. Your presentation?
It's on that PC. I gave it to them. Good afternoon, everyone. I'll be speaking myself, Dr. Hemant Kokne. I'm Associate Professor in Cardiology at BJ Medical College and Sassoon Hospitals, Pune. Where's the presentation? Presentation. याच्यात ठेवलं का पेन ड्राईव्ह Okay. After Sanjeev sir's elaborate talk on leadless pacemaker and Reddy sir's talk on sinus bradycardia, now we'll be discussing something which has come up in quite a big way for last couple of years, last 4-5 years. The thing we are discussing today is an advanced intervention for bradycardia as well as low ejection fraction, which is called as conduction system pacing. So here what we do is we try to maintain the physiology of conduction, try to maintain the physiology of pacing by pacing in an area which basically conducts, which is basically around the His, that is His bundle pacing, which was it was earlier called as, and now it is more of like left bundle area pacing. So the principle here is we try to maintain the physiology of conduction of the electrical impulse. So as we know, the normal pacemaker earlier they used to do RV apical pacing, which later on this was the evolution of the sites of pacing. As we can see that earlier we used to pay there used to be RV apex pace, then there used to be septum pacing, then lower septum, mid septum. It's still being practiced at multiple center. Then came His bundle pacing. There are multiple studies which showed effectivity of His bundle pacing in maintaining the physiology. It is the most physiologic pacing available, but the problem here is the target area, that is the His bundle that we see on the EP, that you have to target. It is quite technically challenging. Also, the area that we are challenging might have fibrosis and all. So there is a problem of high capture thresholds. The thresholds, they went high. So because of these multiple issues, His bundle, the proper His bundle pacing went on a bit of a back foot. And then came the left bundle branch area pacing. There are multiple papers from India as well, and now this has been taken up. So in this, what we do is we pace after the His and where the left bundle area is. So it's not a particular point, it's an area where we pace, and it has got higher success rate and results are equal and comparable to His bundle pacing. And as Dr. Sanjeev sir explained about leadless pacemaker, this is the new. So we have all these 4 pacing modalities available. So in this diagram, this is just wanted to show whether. Yeah, one second. Okay, so here we can see that this is the AV node, the His bundle. It divides into left bundle branch and right bundle branch. So this is the left bundle branch area which we are trying to focus. This is the area which His bundle. This is the His bundle area where the His bundle pacing used to be done, and now this is the area which we are targeting for, which is called as left bundle branch area. So why was His bundle? Why is left bundle branch area more preferable than His bundle area? So although His bundle was more physiologic than left bundle, this, as we discussed, it has a wider area, low and stable thresholds, high success rate in AV block due to possibility of distal conduction system disease, and it provides lead stability away from AV node, resulting in adequate safety margin. So both has drawbacks. In His bundle is they have high capture thresholds and low sense R amplitude. So now let's come to the procedure as such. We have seen normal pacemaker, routine pacemakers. Everyone is quite aware of how they are done. So this is a lead which is available. It's many times it's a small lead, 4 French lead. Actually, there are 2-3 companies which have a different hardware. So other 2 companies, they give normal lead is given for left bundle area pacing. Medtronic is a company which gives a smaller lead, and this is a screw which comes out of the lid, which is to be screwed at that left bundle branch area. Okay, so this is as you can see His bundle where the His catheter is placed, and this is the sheath which goes away from the distal and towards apex of this area, and this is the left bundle area. Here the sheath is taken, sheath is placed, lid is crossed across it, and the lead is screwed in this particular area. So this we have seen already. So first, again, just like a typical pacemaker, we get an IV access, insert the delivery sheet, locate the pacing site. Then what the thing that is different from the routine pacemaker is we have to physically and practically screw the sheath. So this is the video which shows where we take the sheath, place it at the appropriate area, and then we screw the lid across the septum from right ventricular side towards left ventricular side. So as we do that, we have a EP system in place which we monitor the pace. First of all, we do a pacing there, look for the paced morphology, and then we start screwing the lid so that there is a change of morphology. So what we have to see here is when we pace right ventricle, V1 will be negative. So when the screwing starts, as the lid goes inside the septum, there is a formation of R wave in this V1. So this is what we have to monitor, and we have to keep on screwing till there is a R wave, that is a QR in the V1. This is one thing. And second thing, we just have to see the lead V5, V6 and measure the LV activation time, that is time between the paced beat and the peak beat. So the lower the better. So we should target around 65 to 70 milliseconds. And we should have a narrow QRS. These are the 3 end targets. Now, yeah. So this is how we screw the lid. There's a typical motion in which we just have to hold the lid and screw it in a screwing motion. Okay. Also, there should be PVCs while the lid is being screwed. Okay, so this is how the lid gets screwed. And this is how the sheath is there at the septum, and when the lid goes inside, the septum gets crossed. And then we take a fluoro injection. We'll just show the fluoro injection after this. Okay. So this is how the morphology of left bundle area pacing. This is the paced rhythm, and then the V1R. There is a R in V1, and this is a bundle branch paced rhythm. Okay. So first of all, what happens is impedance rises, and then there is a sudden drop by 100 ohms. So that indicates that we are capturing the left bundle area. And but we have to be careful that we don't screw too much and go on the other side of the septum, else there will be a ventricular septal defect. That should not happen. And how do we know that we are going there? There is a sudden drop in the impedance, and there is a loss of pacing. So if that happens, we have perforated the septum. So we have to be careful. We have to target the LV activation time to be less than 75 milliseconds. And we just have to, in the next shoot, so, okay, so here we can see there is a sheath, there is a lid which is screwed inside the left bundle area, and a shoot is being taken to indicate that the area, how much the lid goes inside. One more thing, on echocardiography, we have to ensure that the septum thickness is at least 10 to 12 millimeters, so that because the length of the lid is about 1 centimeter, so we cannot have a very thin septum for it's a contraindication. Also, ideally we should have a cardiac MRI done for all the patients and demonstrate that there is no fibrosis in this particular area, because heavy fibrosis can cause again the capture issues for this. So this is how a lid enters the septum, and this is how it is fixed. Here. Okay. So here we put another right atrial lid, and the procedure is done. So now when we say that the successful LBB pacing is when pace morphology of RBB pattern, that is after pacing the ECG should be RBBB, and there should be presence of LV potential. LVAT should be, it is measured in V5, V6, and there should, so these are all the factors which determine the LVP. I'll just, for the want of time. So, clinically, there are multiple papers coming up, multiple researches, they are showing positive results of left bundle pacing. Randomized control trial, especially one in 2020, it showed that it is much better. They are having much stable lead parameters in left bundle pacing as compared to his bundle pacing. And now, recently in 2023 HRS guidelines, they are saying they have given a class 2A indication for patients with permanent, who require permanent pacing with ejection fraction of 36 to 50%, means moderate LV dysfunction, and who are anticipated to require substantial ventricular pacing. So here, physiologic pacing is class is 2A, and in patients with normal EF who are anticipated to require 2B. So is a HRS recommendation. Also in patients who are ventricular pacing dependent, undergoing his bundle pacemaker placement, his bundle HBP, then placement of additional backup lead may be reasonable to mitigate the risk of. But see, this is not, because of this problem, the LBP, we don't need an additional backup pacing lead. For his bundle, conventionally they used to put an additional pacing lead. So this is not very relevant now of these guidelines. But these two, that is moderate LV dysfunction with heart block, and one who are anticipated with normal EF and who are going to need a long pacemaker, it is recommended to have a, they are given a 2A and 2B in the indicate here. Okay, so this is a flow chart where we are, if we are anticipating substantial ventricular pacing, EF is down 36-50%. We have option of LBB AP or CRT with BIV pacing. And EF is more than 50%, then ventricular pacing is required. I don't know. This is from the guidelines. Okay. Okay. So I'll just wrap it up. So physicians worldwide, they are using guidelines are supporting his bundle pacing. So AV block with narrow QRS failed, no response to biventricular pacing, planned AV node ablation, AV block and broad QRS. They are, but still we don't have LB pacing guidelines. So they are not in the guidelines as such. They are all extrapolated guidelines from his bundle pacing. So less frequent indications are first line for heart failure and bundle branch block and sinus node disease. So yeah, presently we have LBB pacing is physiologic pacing is preferred, especially with low ejection fractions and patients who need prolonged pacing. And we are not covering hot CRT, LOT CRT, where the bundle pacing is coupled with other. So for the want of time. So this is how the ECG looks of left bundle capture. Here we can see this V1, there is a QR pattern. This is very important. And we can see a narrow QRS. And we can see that V5, V6, the LV activation time is less than 75 milliseconds. So this is an ideal left bundle capture ECG. As compared to this anodal capture where the QRS is narrow, but we can see V1 is negative, V2 is negative. And this is the preferred ECG of your patient. Okay. Okay. So this is how the fluoro looks in LAO, and this is how a pacing lead is placed. Okay. Okay. Further other cases, I think we'll have a bit of a discussion rather than discussing the cases. Thank you.
Excellent presentation, Dr. Hemant. I think we all know the adversities of his bundle pacing. The problems of his bundle pacing were that it used to come out, the lead used to come out quite often, yes. And the capture thresholds used to be very high at times because it's the area is not very muscular. But with advent of left bundle branch pacing, I think can we write off his bundle pacing totally? Is that the new future?
We can say that actually. Even left bundle branch also, left bundle capture also. Recently, there have been because see, there is no follow-up of these patients. We don't have a long follow-up. So we need at least for a pacemaker, we should have at least 5-10 years of follow-up to be called. So we can say that way it is still in an infancy. Even this is, you can call it as infancy. The only advantage this has over his bundle is a wider area and a reliable lead that is being placed. We still don't know whether that lead lasts that long or not. Even the lid fractures in his bundle were there, and there have been recent reports which show that LB pacing is also having this lid fracture issues because the lid is very thin. So basically, it is very too early to comment on the longevity part at least. So it is looking attractive, but it will take some time and to be a kind of first line, I guess.
And in last decade, we as interventional cardiologists had stopped doing RV apical pacing, yes, and moved towards septum, more apical septum and mid-septal pacing. So compared to our idea of doing mid-septal and apical septal pacing, is that still physiological, or that is, what's the data on long-term data on mid-septal pacing?
Yeah, just as
without
we discussed,
EP
it is
studies, without LBBB.
Yes, absolutely. Just as we discussed, anything that is closer to conduction system is always going to be better than the apex. There has been quite data on septal versus apical. Apical is now quite abundant all over the world. So we're not speaking of apical. Even though when we say a typical pacemaker, we always consider that it is a septal. So it's septum versus physiologic. This is what we are talking. So physiological has shown promise, but again, lead, the longevity, the thresholds, and these issues are yet to be they are yet to prove their metal, basically.
One just last quick question. The Medtronic system of LBBB pacing that is quite in vogue now.
Quite in vogue, yeah.
They have done a lot of cases with surface ECG also.
Yes.
They only
Yes, they are
see
doing it.
W pattern in V1. They say that it's on the RV side of the septum, and then they screw it. So, is surface ECG also okay for going for LBBB pacing, or after a learning curve we should start doing that?
No, first we put a temporary pacing lead, so that is your marker of RV entry. Then if a EP system is available, you place a His catheter, and we exactly know ki, ahead of this His catheter to RV apex, this is the area from 1 centimeter you have to target after the His catheter is placed. Surface ECG, so ideally speaking, first few cases, if are done on this, at least 5-10 cases, you actually get the judgment of that area, which area we have to target, the left bundle area. And based purely on ECG, yes, it can be done, but as you said, after some practice, it is advisable to get it done. Because we don't have a marker for His. Without EP system, we just have a marker of temporary pacing catheter. That's the only fluoro marker we have got. So rest all is kind of imaginations. His gives you a good marker, electrical.
So, if I may add something, so for your first question, His bundle pacing is obviously not out of the picture, because that is the most physiological pacing available right now. It is difficult to do. So if you are like starting out the conduction system pacing, you might go for a left bundle pacing, but then it is better to thrive for the His bundle pacing whenever possible, because that is the most physiological pacing which you can give to the patient. And the chances of dislodgements are coming down with the technology advances, the hardware advances. Now we have something called as stylet driven leads. Now most of the data which sir has showed is with the 3830 Medtronic lead, but there are some stylet driven leads which have become sturdier now.
Yes, sturdier.
So it is better to have His bundle pacing whenever possible. Second thing you can do, and rather people are doing conduction system pacing without the EP system now. Like there are more and more ways to do it without the EP system, because it is not available everywhere. That is a practical problem. So there is a very nice paper published in 2019. I forgot the author. So they have described something called as pseudo V1 and pseudo V6, 2 leads. So you just change the connections on your, so there is a programmer, you know, the device people bring the programmer. So you make the attachments in a way that your programmer itself shows you a V1 and a V2. It will not be labeled as V1, V2. It will be labeled as 1, 2, whatever the programmer has. But it will actually show the V1 and V6, because those are the 2 leads which you require for a conduction system pacing to find out. So we, as you rightly pointed out, we look for QR or W pattern in V1, and V6 we look for the LVAT, the LV activation time, and there is a parameter called as V1, V6 time. So those are the 3 things which can give you a fairly good idea. So even if you talk to the pioneer in the field whose study was showed just now, Dr. Vijayaraman, he also himself says that there is no 100% way to predict that you have captured the left bundle. But these are some of the surrogates on the ECG, or if you actually see the left bundle the EGM, and you see there is something called as current of injury, you might have seen. So current of injury at the place of left bundle, that is the only definitive way to tell that it is a left bundle capture. Otherwise it's very difficult to say that.
I would like to ask one thing. What is the difference between the cost of regular permanent pacemaker and His bundle pacemaker?
The cost is not very different. The sheath that comes, which is used to place that particular lead, which is not required in the normal pacemaker. So I think that cost gets added to the normal dual chamber pacemaker, and lead is slightly expensive. So I guess dual chamber pacemaker plus 50,000-60,000.
Is it covered under MJPGI?
MJPGI will not cover. MJPGI only covers single chamber.
You are working in BJ, so you...
Yeah, it doesn't cover, obviously. It doesn't cover, obviously. Yeah.
So how to convince that
it is, yeah, but it is not very expensive as compared to a dual chamber pacemaker. Yeah, definitely.
LBBB pacing be an option for patients with LBBB with LV dysfunction as compared to CRT? It's a traditional way of...
Yes, yes.
Would LBBB pacing
Yeah, that's all a lot CRTs and they are coming up. So you have moderate LV dysfunction which are not fitting the criteria for CRT. Without, yeah, we can, LB pacing is, yes. We have a narrowing of LBBV properly seen on, so it is used definitely. But again, patients with very low EFs and LBBV, they have thin septums. So the septum criteria many times goes. And also if there is a DCMP, then the fibrosis, we need an MRI and everything. So it's a bit of a tricky thing. Thank you.
Thank you, sir. Panelist and chairperson, please felicitate our speaker. Our next speaker will be Dr. Saurabh Deshpande. Our chairperson, Dr. Rajesh Mata. Dr. Kaushik Kulkarni, Dr. Sanjay, Dr. Suresh Ade.
Hi everybody again. I will not take your too much time because I know everybody is hungry. I am also hungry. So this list might look very long, but I will not take it that long. Basically, defibrillation means you are delivering a high energy current from inside the heart or sometimes outside the heart. Something like this happens. You have you have something like this going on. You shock. There is a pause, and then there is a normal rhythm. Always remember this, I wanted to highlight. The heart is stunned for the time you have defibrillated the heart. So if this does not start, please start CPR. So never stay away from the patient. Ha, ye ho gaya. No. If this does not come, patient will not come back. So that is one thing which is important in defibrillation when you look for such patients. So there are multiple types. You have an external defibrillator, which you all have seen in the emergencies and cath labs and everywhere. There are internal. There are transvenous, subcutaneous. So my topic is mainly the newer advances. So I will not dwell upon these routine ones, which have been discussed as like a pacemaker. Obviously, these two people are the ones whom we have to thank for ICD whenever we talk about ICD. So this picture you will see in all the ICD talks. This is how the evolution came from the way back in 1980. And now we are looking at something called as subcutaneous ICD in nowadays. Indications are most of the times clear-cut. Sometimes you have to prevent the event where there is channelopathy or severe LV dysfunction. If there is already an event which has happened, it is secondary prevention, and you have to prevent the sudden cardiac arrest in future. Now you have different types. You have single coil, dual coil, you have single lead, dual lead, you have 3 leads, or sometimes now, as Dr. Hemant sir was talking about something called a lot and hot CRT, where there are 4 leads. So the leads are increasing day by day. The purpose of showing this particular picture is when you talk about ICD, you should be aware what all things comprise of ICD, because that is where the newer advances are. So ICD has the programmer is, we are not worried because it's outside. We have a device, we have a lead. The device has a battery, it has a capacitor, so that is the only thing which takes the maximum space inside the hardware of an ICD. Then you have circuitry, which is somewhere around here. Then you have leads. You have leads which have 2 types of electrodes. You have a pacing electrode, you have a defibrillation coil, and you have something called as these connectors. So this is where the evolution has happened. In all these things, that is where the changes have happened over the time. So way back in 1980s, we had minimally programmable ICDs. 90s, we had ATPs, which we discussed in the morning, anti-tachycardia pacing. And the current generation ICD has everything which is there, and then newer and newer algorithms are coming day to day. as the days are going. This one thing I wanted to highlight because the companies are using different technologies of battery, and few of the companies are with certain lithium, silver, vanadium oxide, carbon tetrafluoride type of batteries, and some of them have shifted to lithium manganese dioxide battery. So what the studies have shown is lithium manganese dioxide has a maximum, so this is the average R, which is the capacity of the battery which is considered. It is highest for these lithium manganese dioxide batteries. Rest are slightly lower than that. This was the difference in something called as DF4. It was introduced in 2010. So if you see here, there was a huge bulk. 3 connectors used to be there in the older, so-called older DF devices, which are DF1 devices. The newer devices, they have come up with something called as DF4, which is a single lead, out of which the first and second electrode are low voltage electrode for pacing, and the second and third electrode are for the coil. This is a very, I would say, it will take a few years to come, but something which is called as a conduction system pacing ICD. So you discussed conduction system pacing some time back, but whenever you have to put an ICD for the patient, you have to put one lead in the apex for the coil and second lead in the conduction system pacing. This particular lead will obviate the need of that. Sorry, I have gone too ahead, I think, yeah. This particular lead will obviate the need for that, and you will have both coil and the pacing electrode in that. But it will take some time. This all was discussed at the time of leadless pacemaker. So similar to the leadless pacemaker, now what is happening is we are taking the lead out of the heart for the ICD as well. So there are 2 systems which are there available. One of the systems is available in India. The other one is not still available in India. So the first one is the subcutaneous ICD. It has received the FDA approval in 2012. This all components are there. I will not bore you with that. So the ICD is put here. Here it's in the axilla. It's in the serratus anterior muscle. And the lead goes, it is tunneled actually from here to just on the medial side, the left side of the sternum, below the sternum. So these all things I will not discuss. There are multiple implantation techniques and some places where you put it. The AHA-ACC guidelines 2017 included it for the patients who have inadequate vascular access, the ones similar to ones which Kalkekar sir showed you, but you need an ICD, then this is an option. And whom bradycardia pacing is not indicated. This is very important because this subcutaneous ICD is not actually equipped of giving any bradycardia pacing. So the patient should not have any pacing requirement if you are planning a subcutaneous ICD to be put inside. There is something called as Empower system, which is again still in pipeline. What they are planning to do is they are planning to combine this Emblem ICD with the Empower leadless pacemaker. Leadless pacemaker you heard from Dr. Kalkekar sir before. So the leadless pacemaker will be inside the heart, the SICD will be in subcutaneous area, and these 2 devices will communicate with each other, and that is what is called as the modular cardiac rhythm management system. So what they are planning to do is introduce ATP through this particular device whenever this ICD detects a VT. But it will take some time. There is some animal study and it has shown very promising results. Let's hope this modular ATP trials gives us some extra insights. This is something which is again very new. It has still not received an FDA approval. It is still undergoing studies. So it's written Medtronic, but actually it can be used with any of the companies. This particular thing is the newer advance. That is a new lead. And it has, as it's shown here, it has a pacing vector, sensing vector, and these 2 are the coils, coil 1 and coil 2. So it is again similar area, the pocket will be, lead will be similarly placed, but the difference will be, this will be below the rib. It will be just above the pericardium, below the rib. So the contact with the heart will be better with this EV ICD lead than the subcutaneous ICD lead. So this is where you will appreciate that. Here it is shown, this is the applicator tool. Here the lead is coming out like this. This is below the rib and it is going inside. These are all this has not been, it's still undergoing study in humans. It is just an animated picture, you would say. So this is the initial experience. It has been, so there are two phase 1 and phase 2 studies have been done, PASS, PUL EV and Secure AV studies. They have used all 4 available PGs, and it has been found to be safe and reliable method in terms of defibrillation, sensing, and all the important things associated with ICD. Just a point on something called as antibiotic envelope, which is again important in some cases wherever you are anticipating high risk of infection, specifically in CKD or in patients who already had a history of infection in the past. So you have two types of envelopes are available. One is non-biological envelope, which is called a Tyrex. It's available with Medtronic. And you have a biological envelope, which is available with Azayo. It's not there in India. It's called Kangaroo. So this is that, and this is the Tyrex. You can just wrap your device inside with the pouch and then put it inside. It will get absorbed over a few days. So in summary, ICD has gone through a lot of change. It is basically to include the patients which were excluded earlier in the study to put an ICD. Subcutaneous ICD and EV ICD will give us a path to put it in the patients who have infection or venous obstruction where we cannot put the lead inside the vein. Thank you.
So excellent talk by Dr. Saurabh. Anybody has any questions regarding this ICD? So basic job of an ICD is to give a shock. We need to understand that subcutaneous ICD currently has certain limitations of not being able to give anti-tachycardia pacing. And I think we'll be coming up with a new device in the next 5 to 10 years, which will be able to do that as well.
Thank you.
Thank you all. Next, Dr. Hemant Kokane, our speaker, and the last session. Chairperson Dr. Anand, panelists Dr. Vinit Shinde, Dr. Vaishali Lokhande, Dr. Shailesh Palekar.
So, good afternoon. The last topic for the day, and I understand. So, I'll try to keep as short as possible. So, this is one very important clinical topic that everyone encounters in their day-to-day practice. A patient comes with WPW pattern on ECG. I'm saying pattern. And you don't know what to do next, whether the patient needs to be sent for EP, whether the patient needs to be put on medical management. Especially, he's not a patient, first of all. He's just an individual having a typical ECG. So, let's see, what is this WPW, Wolff-Parkinson-White? I'm sure everyone here has seen an ECG of WPW. So, it's nothing but an accessory pathway. And it's a conduction tissue present between the atria and ventricle, and it conducts basically. So there are two conduction pathways for that particular patient. Patient has a conduction through AV node, which is decremental, and through accessory pathway, which is non-decremental. We are not talking about some exceptional circumstances where these can also be decremental. Decremental means the heart rate, as it increases, the conduction decreases. It slows down as the heart rate increases. And this particular accessory pathway gives you a delta wave on the ECG. And because of this delta wave, the PR interval, this is normal PR interval, it appears to be shortened. So this is a short PR, this is a delta wave, and because of this delta wave, the QRS widens. So this is a triad of WPW syndrome. So, shortened PR, less than 120 milliseconds, slurred upstroke, that is delta wave, and prolonged QRS. It is the incidence through multiple literatures. It is about 5.5. It's about 1 to 3% per 1,000 individuals, not percent, 1 to 3 per 1,000 individuals. But among first degree relatives, it's about 5 to 5.5 per 1,000. So, I'm just revising the ECGs that you have seen. This is how a right free wall pathway looks. We can see there is a late transition that is negative, 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 and positive. You can see the delta, you can see short PR. Okay, so this is the right free wall pathway. Left pathway, we have a bang positive V1, the short PR, and it's positive, and you can see a delta wave here. Okay, so there are different types of W, and why it is important, we'll come to it later. This is a commonly seen, the most common one is left pathway. Oh, sorry. The most common is this particular pattern. Second most common is this pattern, where we have a delta, and the delta is near in a posteroceptal region, which is indicated by transition. There is a negative V1 and a bang positive V2. Okay, so this is called as transition. So this transition is at V1, V2. So this is a septal pathway, and we can see 2, 3 AVF negative. This particular ECG is very commonly confused as inferior wall myocardial infarction, and these patients unnecessarily undergo angiographies, and invariably I have hardly seen any patient without an angiography of this particular ECG. So just wanted this take home point, even if taken and not posted for angiography, is I think the success of this conference. You don't do angiographies for these 2, 3 AVFs. Okay. This is one of a rare pathway, that is anteroseptal pathway. 2, 3 AVF here becomes a bit positive, and again the transition is at V1, V2 level. So this is one of the rare septal pathways. Importance is if we try to ablate these pathways, there is a very high chances of heart block. These are very close to his bundle. Okay, so why do we need to assess asymptomatic patients? We have a WPW pattern on ECG. Why do we do that? What is the need? So they have find out that multiple literature has come up with a figure of 0.1% per patient per year risk of sudden cardiac death, even in asymptomatic patients. Now the interesting fact is the first manifestation in an asymptomatic patient. A patient is asymptomatic, he doesn't have any symptoms, but 53% of the patients will present with sudden cardiac death as a first manifestation. So the most common manifestation in an asymptomatic individual, if ever it occurs, is sudden cardiac death. So we need to evaluate that. I'm not saying we need to ablate that. We need to evaluate that particular ECG. We need to see what kind of pathway we are dealing with. Okay, so how do we risk stratify? The principle of risk stratification, I mean, to assess whether this pathway is malignant, whether this pathway is life-threatening, is evaluation of anterograde AV conduction rate over the accessory pathway through non-invasive or invasive testing. Means conductibility of the accessory pathway, how well it conducts, how fast it conducts. That is the only that is a very important determining factor for its malignant nature. Okay, other clinical factors that you all here can assess is male early onset, that first 2 decades of life, patient presenting with atrial fibrillation, arrhythmic symptoms like syncope, then Epstein's associated WPW. We know Epstein's has multiple pathways, mostly are right-sided, and also patients of WPW on ECG with going for high-risk occupations like pilot, drivers, even divers, the sea divers, and other high-intensity sport participants. So as we have seen, this risk of acid is about 0.13%. So what are the non-invasive means of to assess WPW syndrome? In your clinic, in your non-invasive, how can you see? So before coming to non-invasive assessment, there is one concept we need to understand is loss of ventricular pre-excitation and shortest RR interval in atrial fibrillation. So shortest spaced RR in atrial fibrillation. So here we can see these are the two important things, two important parameters which we need to see. So if we have a ECG of SVT, if we have a WPW and we have a SVT or tachycardia, any tachycardia if you see, and at one point there is no pre-excitation, This is called as loss of ventricular pre-excitation. This indicates that this WPW will not cause death of the patient. So, accessory pathway has stopped functioning at this level, at this heart rate. So, that will come to the what heart rate is important, but this ECG you should be fine. You should find a normal non-WPW beat amongst all WP or amongst all pre-excited beats. There should be a non-pre-excited beat, which is called as loss of VPV. And if you find this particular beat in normal ECG, in Holter, in treadmill test, or anywhere if you find this beat, it is reassuring. So that particular patient at high rates does not take accessory pathway for its conduction, and it conducts through normal AV node. Then if a patient presents with atrial fibrillation, so we have to see that pre-excited beats, what is the fastest that they are conducting? The Sperry. So this is a pre-excited beat, this is a pre-excited beat, and this is the fastest pre-excited beat. So the interval, the lower the interval, the worse for the patient. So we should have these values higher, and we should have these values higher. So these are two things. Now coming to the theory. So the VPE, the loss of VPE that we have discussed, it has a 100% specificity, but it has low sensitivity. Means we have to search for it more aggressively. So the good thing is that we can search it non-invasively. So we have to go through more and more treadmill tests, more and more Holter data to find out this. But if you get it, it's 100%. So 100% specific, that it is a good indicator. And okay, so now here one more important component that you might see. The word that there was loss of VP was sudden loss. Okay, so if you have this kind of ECG where there is, so this is what we want, no pre-excitation, abruptly going pre-excitation. There is no pre-excitation here, there is pre-excitation, pre-excitation, pre-excitation. Okay, so these are all pre-excited beats, and there is abrupt loss of pre-excitation in this particular beat and this particular beat. So this is what we want. Okay, what we don't want is this. There are pre-excited beats, as we can see. Okay. Okay, yeah, sorry. So the pre-excited beats, no pre-excitation, pre-excitation continues. This is what we want. So you're just in a normal ECG, this is perfect. In a fast heart rate, this is perfect. So these are the two things that we need to see. Okay, so the point here was different. So here, if you have pre-excitation, which goes on, which starts disappearing gradually, you can see pre-excitation that decreases, and there is you can't find out at what point the pre-excitation actually went away. Unclear, it is unclear. So this is called as gradual loss of pre-excitation. This is totally different phenomena than sudden loss of pre-excitation. This is same as present pre-excitation. I mean, pre-excitation is present. So progressively less contribution of ventricular activation through the accessory pathway, and large contribution through AV node to ventricular activation. So the contribution of ventricle goes on decreasing. That's it. So this does not indicate a good prognosis. This is just present pre-excitation. So we should not be confusing this gradual with the earlier. Rarely used nowadays is a pharmacological test. We could give procanamide, propafenone, ajmalin, which decreases antigrade AP conduction. So these are not used nowadays. So this is how we can test non-invasively. Now, EP, when you post the patient for EP study, we need to find out accessory pathway ERP. So less than 240 of the AP ERP, which is same as loss of ventricular pre-excitation, and Sperry less than 250 are considered as high-risk features. So these values should be more than multiple. There are different articles suggest different values, but roughly around 250 and 250. More than 250 and more than 250 are a good sign of, they are good prognosis. Sperry measurement is superior to APRP measurement in discriminating patient at risk for sudden cardiac death and who may benefit for ablation. As we've seen, it has got a good specificity. VF is found to be very unlikely if Sperry is more than 250. So if it is more than 250, VF is less likely. So that's why it indicates protection from sudden cardiac death. Okay, so I'll skip this. Okay, now whom to ablate? So accessory. So again, the same thing. The thing is, if we take these patients, so we have this like APs less than 250, and we take the patient for EP study, and we are able to induce AVRT, then yes, we need to ablate. Also, there could be multiple accessory pathways, and they increase the risk of life-threatening arrhythmic events by an odds ratio of 3.1. So so we need to address these on the EP study. Also, one more limitation of EP study as compared to physiology we need to understand is we will never be able to mimic the exact physiology of the patient when he gets arrhythmia in EP lab. So we have multiple drugs. We can give isoprenaline, we can give atropine, we can give all kind of drugs. But the natural patient, whatever happens in patient when he gets tachycardia, it cannot be actually mimicked. So that is that is one small limitation we have for EP studies. So we can have false negatives, and we should avoid giving anesthesia as much as possible, because anesthesia will reduce all kind of conductions, change all properties of the conductions. So patient should be on minimum sedation and minimum anesthetic drugs. So in accessory pathway, the success rate is more than 95%. So why don't we just go ahead and ablate all WPWs? You get a WPW, why to do risk assessment, and why not just get it away, get the track away? Because there is a small risk, 0.1% of sudden cardiac death even in asymptomatic individual. So EP study itself and ablation itself have complications that we need to know. AV block is reported around 0.17 to 2.7% ablations, especially high if we are dealing with the pathways which are close to AV node. Then there is a risk, then other standard risk like perforation, tamponade, stroke. When many times we have to take transeptal access to go to the left side, that is my left pathway, which is the commonest pathway. So that access we need to take by taking a small puncture on the intra-atrial septum, go on the left side and ablate. So if there is any clot which can embolize, then even some pathways are very close to coronary artery. So we have to be careful that we don't damage coronary arteries during ablation. So these are all the risks of ablating pathways. So basically we have to balance a small 0.13% risk of clinically important arrhythmia with 0.17 to 2.7% of serious procedural risk. So this is the management. So as the conference today is all about talking with the relatives. So again here also we have to talk with the relatives. We have to first of all assess whether the pathway is high risk accessory pathway and low risk accessory or low risk accessory pathway. Then we have a clarity of ourselves and we'll be able to guide the patient correctly. So we have to find out the risk benefit ratio, whether it is favoring ablation or not favoring ablation. So this is all this assessment by electrophysiologist is very important. So some pathways which are very close to AV node are high risk. They can cause heart block. So there we can just avoid ablating them and put them on medical management. Some pathways are at a relative safer location, away from the AV node. There we can be slightly more aggressive. So and then the patient's demand, what patients want. Then these things can be balanced and patient can be given the right choice. So the flow chart here as given by ACC is asymptomatic. If you find 2015 guidelines of ACC-AHA, so first of all we have to do ambulatory monitoring, that is non-invasively, find the clinical risk factors. If there is a VPE or a high risk feature, go for stress test. If there is intermittent VPE on your non-invasive testing, that is ECG, Holt or anywhere if you find, just do a follow-up and counseling. And if not, then do exercise stress test, find out that VPE, loss of VPE, and then again keep a follow-up. Whenever you find a loss of VP, the further workup towards surgery stops, and you just have to keep the patient on follow-up. If you don't, persistent or uncertain loss of VP, high-risk features, unable to perform treadmill or something like that, then we can post him for diagnostic EP study. And on diagnostic EP study, we can do all the maneuvers. We can find out SPERI, we can do AP-ERP, we can find out multiple pathways, we can find out inducible tachycardias, we can find out whether AF is inducible. All these things can be studied on the diagnostic EP. And if the patient is still asymptomatic but diagnostic EP is showing anything of this, we can consider for catheter ablation. Again, we have to talk with the patient that we have got one of these positive factor, like we have multiple pathways or any other factor, we have got positive on diagnostic EP and it is a low risk. Should we go ahead with the ablation? So patient decides whether he goes ahead with the ablation or not. So this is the flow chart which is the crux of this talk. Okay, so there was one study, I just found it very interesting. They did a transesophageal EP study. This is in pediatric population, this kind of EP study is done where you put a catheter through the esophagus into the posterior part of the heart and do the pacing in WPW syndrome. And they studied all these parameters on that. So the moral of the story here was children and adolescents with WPW have a higher rate of AVRT inducibility than asymptomatic patients. However, no differences between two groups were found in atrial vulnerability and parameter related risk of SCD. So for SCD, whatever they studied, as younger the patient, the more the risk of more risky the accessory pathway becomes. So finding that accessory pathway at younger age itself is a big thing. So is an important risk factor. So even this said that they both were same. So at what age you pick up the patient presence is important. So 2015, there are two guidelines for this particular concern. One is 2015 guidelines of ACC/AHA. They say that class 1 indication in asymptomatic patient for ambulatory monitoring needs to be done, and if there is a AVRT, there is pre-excitation, then we go ahead with, if ablation candidate willing to undergo ablation, go with a catheter ablation if patient has AVRT, and ablation candidate if prefers, then we have other drugs like flecainide, amiodarone, which can be given. So this 2019 guidelines have given more clarity. Basically, they have said that class 1 indication, this slide is not clear, sorry for that, but we can perform EP in a patient with asymptomatic pre-excitation who are high-risk occupation, like as we discussed, pilots or navigators, or so this is a class 1 indication. Also, if a patient has SPERI less than 250 or APRP less than 250, it is a class 1 indication for EP study and a catheter ablation. And it is recommended in high-risk patients with asymptomatic pre-excitation after discussing the risk, especially of heart block associated with ablation of anteroseptal. If the pathway is at a difficult place, anteroseptal, then we can have a discussion with the patient, explain the risk of pacemaker, explain the risk of AV block, and then we can go ahead with the ablation. So these are important class 1 indications for according to 2019 European guidelines. Okay, we'll skip this. So finally, take home message, EP study is optimal in patients with asymptomatic pre-excitation and should be based on careful discussion with the patient, which includes potential risk of ablation versus a small time risk of arrhythmia. So the cardiologist, physician, or a EP person has to balance that risk for the patient. Intermittent pre-excitation, that is loss of pre-excitation, suggests an accessory pathway with a long ERP, that is effective refractory period, and it should be reassuring and the patient needs only follow-up. And that intermittent pre-excitation should be distinguished from gradual pre-excitation on ECG. That is one important point. There are medical therapy, we have class 1 and class 3 antiarrhythmics as option. Then ablation of accessory pathway near the AV node carry the high procedural risk of damaging the AV node, that is 0.17 to 2.7%. Other potential complications, as we know, perforation, tamponade, stroke and damaged coronary arteries are there. So, yeah, thank you.
Any question? From the audience. Dr. Charan, any question?
Actually, I have two questions for you, sir. Very nice talk. As a physician, we see so many ECGs with short PRs, but there's no delta wave, no pre-excitation. These are mostly pre-op patients or health checks, or people who have come for a routine checkup. So should we ignore that short PR? Should the patient undergo a TMT to maybe induce something of that sort? Is there a cutoff where we should be more concerned about this patient? That's question number one. Question number two is, if you said that SPERI should be less than 250 milliseconds for it to be a serious one. So a short, RR interval of less than 6 milliseconds is enough for us to take a call that this is a serious one and suggest EP study aggressively to the patient. And third question is, if there are multiple pathways, can that be picked up on the ECG itself?
Yeah, I'll answer questions one by one. So basically, the SPERI is on atrial fibrillation. When you get atrial fibrillation in that particular patient and you have a documented ECG, then we can calculate SPERI, or you have to do EP study to get it. Secondly, clinical analysis of the patient, the risk factors that we discussed. In purview of that, we can assess the risk of the patient and see. If we are able to find ventricular loss of VP, then we just leave the patient. We just reassure the patient and it's the end of the story there itself. We don't need a EP study. But if you are not able to get if you're not able to get VPE, or there is a prominent delta, or patient gives history of similar illness in family, or patient gives history of palpitations, or syncope, pre-syncope, anytime in the past, that needs to be taken seriously, and we need further investigation and workup on that, definitely. And about what was the last?
Multiple pathways can be picked up on
No, it is very difficult because each pathway rotates the axis of the accessory pathway in such a way that it is practically not possible to diagnose multiple pathways on ECG.
So can I say if there's non-congruous lead involvement, like inferior wall pattern was one, then
Yes.
there was one septal wall pattern.
Yes.
So if there are non-congruous lead involvement, will that be a surrogate? Again, that's just a suggestion or a question.
If patient has abstinence on echo, then we can be assured, but that it is. But rest, it is very difficult to say. Abstinence should have a right axis on ECG, but if it has, as simple as if a patient has left axis in abstinence, we conclude that it's because of axillary pathway. It's very simple, but only in abstinence it is quite true. So multiple pathways in a non-abstinence is very difficult. It's not possible practically on ECG.
And plain simple short PR can be left alone?
Plain simple PR, short PR can be, because it does not fulfill the criteria for WPW syndrome. Saurabh, yes.
If I may add, madam, whenever you have short PR and you think you want to rule out a accessory pathway, there is a very simple way to do it. Just give adenosine. We have discussed adenosine a lot since morning.
That's a contraindication for WPW.
No. So this is sinus ECG you are talking about, right?
I mean, otherwise it's supposed to be contraindication.
That is AF with WPW is contraindicated. Yeah. So if I have a sinus rhythm with short PR and you are not very sure whether there is pre-excitation, just give adenosine. What it will do is it will block the AV node, and your pre-excitation will come out if it is there. So if you want to be very sure, that is one way to do it.
I have a slight disagreement on. I would like to take a different view on this. If there's a short PR and you're going to send a patient out for surgery, short PR occurs only when there's an accessory pathway. There is no other place where short PR is seen. So it is a surrogate marker for accessory pathway. That's one, and that suggests extranodal conduction, which way or not, because there's no other thing in EP where you see short PR. If you're going to send a patient out for surgery, during the surgery there is surgical stress, there is anesthetic alteration, and autonomic modulation. All these three happens in any patient who undergoes surgery, regardless of whether it's maybe not so much for local anesthesia. So I would, if you send the patient to me, I would definitely investigate rather than assuming that it would be safe.
So I'll take some liberties. There are no surgeons in the audience. They don't like too many workups pre-operative when there's a package. So I write, watch for arrhythmias, atrial fibrillation, and post-op SOS monitoring ICU. That's how I kind of cover myself. And of course, take care of the patient.
Yeah, that's legit. But pre-operatively, if you say if somebody in the hindsight comes back and say, why did you not say if somebody has a VF? And if it's a young kid, AF incidence is very small. So children, you can just let them go because AF in children is a rarity. There's not even literature on that. But if you're talking about adults who have their short PR and they come up for surgery, and if it's a slightly longer surgery, then their risks are not as much as any other person. That's what you want to, when you're weighing a person, whether he's at risk or not, when you compare the next patient who does not have that. But on what basis are we claiming that that person is as safe as a second person? The answer is we don't know.
I mean, that's the whole point. How long can we stretch this and how much will the patient and the primary consultant accept and agree with this?
Yeah, so you have to discuss this with your surgeon and say that 0.1% risk can happen on the table. Are you willing to take it? If the surgeon says, yeah, I don't mind.
We have got many brave people here. You are not aware of that.
I'm not one of them. But I would definitely not give a cardiac clearance if it comes to me. Because I don't want, I'm averse to complications.
Thank you.
Thank you, Hemant Singh.
Thank you.
Thank you, sir.
Thank you, sir.
I would like to thank for Apollo administration for providing help for this conference. Thanks to Abort Pacing Division for sponsoring the event. Thanks to API and Navi Mumbai for actively participating. Thanks to all the audience for active contribution. Let us make this formal event a memorable one by taking a photograph, please. Requesting everyone to come on stage, please. Everyone, please. It's not done? Done, no? Zale panelists, sir.
खत्म कर दिया क्या?
नहीं सर, नहीं खत्म हुआ है।
अच्छा, कॉन्फ्रेंस खत्म नहीं हुआ?